everyone to our World Diabetes Day scientific webinar entitled Diabetes Update, Tribute to Nurses. Thank you, all of you, for being with us. Dr. Nisreen, we're ready to hear your words.
Good evening, everyone. Dear attendees, please allow me first to greet all our guests attending from USA, Canada, Germany, UK, Tunisia, Libya, India, Pakistan, Algeria, Egypt, Qatar, Kuwait, Saudi Arabia, United Arab Emirates, Yemen, Jordan, and Turkey, in addition to attendees from the Lebanese Ministry of Public Health and from hospitals, schools, universities, and other organizations from North to South Lebanon. Dear colleagues and conference attendees, it could not be more timely that the World Health Organization designated 2020 as the International Year of the Nurse and the Midwife. The main aim was to recognize the contributions of nurses to the health and well-being of populations and highlight the challenges they often face. But then the COVID-19 pandemic happened. Nurses in 2020 were and are still on the front lines of the COVID-19 response. Many of them have lost their lives, along with physicians and other healthcare workers, to save others. Now, the message is clearer than ever. It is vital that we advocate for increased investments in the nursing workforce and equip nurses with leadership skills they can guide health policies and lead and inspire the next generations to save lives. To all the nurses around the globe, and especially the nurses in Lebanon, working under the current exceptional circumstances, we say a big thank you for your courage and sacrifices to keep us all safe. Beirut Arab University has attained an international reputation through its rich research output, international accreditation of its educational programs, and its continuous contribution to the community at different levels through the organization of public and scientific activities. From this perspective, it was a great pleasure for the Faculty of Health Sciences to co-organize and host the event today in partnership with DiaLeb. Many thanks are due to Dr. Jackie Malouf, President and founder of DiaLeb, as she coined the idea of celebrating the World Diabetes Day this year with a scientific webinar covering the latest challenges in diabetes care and treatment while paying tribute to nurses. Also, on behalf of Beirut Arab University, I thank the International Diabetes Federation and Order of Nurses in Lebanon for their contribution and support, and all speakers today for making this event a reality. I would like also to thank the members of the Public Relations and IT departments at BAU for their valuable efforts in the preparation of the webinar. Finally, I thank the attendees for their interest in this event, and I wish you all a pleasant and informative evening. Thank you. Now I will give the lead to the President of DiaLeb, Dr. Jackie Malouf. Dr. Jackie?
Thank you, Dr. Nisreen, for your nice words. I would love to say that a couple months back, organizing a scientific webinar for DiaLab was only an optimistic idea. It took one phone call to Dr. Khalid Baghdadi, Vice President of the Beirut Arab University in Tripoli. He did not hesitate 1 second when I proposed this event. So thank you, Dr. Khalid. Thank you, Dr. Nisreen, because you were at the top of every detail, and your professionalism, dedication, and cooperation, along with all the team at BAU, made this event possible. Big thanks to IDF President, Professor Andrew Bolton, our keynote speaker. I know how busy you are. Thank you for giving us this time. Thank you to IDF MENA Chair, Professor Jamal Belkhadir. Thank you for your permanent support. And big thanks to Dr. Mohammed Sandid, IDF MENA Chair-elect, who is also with us tonight. And I would like to mention that those countries mentioned by you, Dr. Nisreen, many of them are our colleagues and supporters from IDF MENA region. Thank you for being with us, all of you tonight. Big thanks to the Order of Nurses in Lebanon and especially to President Dr. Mirna Doumet for trusting our scientific program and granting 2 CNE credits to each registered nurse attending this webinar. To our fantastic speakers, I can't thank you enough, all of you, for being with us today, sharing your expertise. I hope our distinguished attendees will benefit to the maximum, and I would like to invite you to stay updated with DiaLab's activities, and they are many, by the way, and to help us better serve the community. Remember, you are an important part of the diabetes network care. Today, we are focusing on two important topics, role of nurses and insulin centenary. I would like to pay my personal tribute to every nurse out there and to all the healthcare professionals facing all the challenges in today's world in order to complete their mission. In relation to the insulin centenary, I would like to borrow and quote Professor Andrew Bolton when he said, "We should not celebrate the discovery of insulin. We need to work to make it accessible to everyone." Having myself a daughter living with type 1 diabetes, I would like to say, God bless Dr. Banting and Dr. Best, who discovered the insulin 100 years back, and everyone who have worked since then to improve it. Why? Simply because insulin is life. Allow me to share now only a few slides where I would be letting you know a little bit more about DiaLeb for those of you who don't know DiaLeb yet. So, as every NGO, we have a mission, and it's a beautiful one. It's to improve the lives of people affected by diabetes and to help them in its prevention by promoting healthy lifestyles. Our vision is definitely to stop the rise of diabetes and improve the quality of life of diabetes patients, ensuring access to quality healthcare and life-saving medication. Many objectives definitely we have in mind, and they are to raise the awareness and develop well-designed communication strategies to disseminate appropriate information, to help with the affected people improve their lives and especially the quality of their lives, to deliver community programs, and to facilitate the progress in researches. We are proud members of the International Diabetes Federation, IDF, since 2016. And I'm sharing with you a couple pictures from our latest meeting in Busan, South Korea, last December. We are also members at the United Nations Global Compact, working towards specifically SDG number 3, related to good health and well-being, and SDG number 5, related to gender equality. I'm sharing here the map of our beloved Lebanon. The red dot symbolizes the cities and town where we've reached out for awareness and where also we have been distributing diabetes medication through our initiative, Diabetes Medication for All. I hope to see this map covered fully by red dots when we accomplish our mission and do that. I would like to share just the titles of our programs. You are welcome to surf our social media and website to know more about these programs. Diabetes in the Classroom is our program for schools and universities. We have Diabetes in the Community, community internship programs, and I know we have many students attending today in different specific majors. I would like to invite them to know more about this program if they are interested to contact us. We have a summer camp for type 1 adults, for people with type 1, only the adult ones, that we do every year. Unfortunately, this year it was not possible to do. We have our educational webinars, the World Diabetes Day activities, and fitness and sports activities, very important definitely for diabetes. After the unfortunate Beirut blast, DiaLeb launched its initiative, Diabetes Relief. Since then, we have been working very hard in very difficult circumstances. And thanks to you, thanks to your donations, thanks to your support, we were able to get to these numbers. For sake of time, I will not say the numbers. You are seeing them right in front of your eyes. And just sharing a couple pictures to tell you how difficult it was for many people to get to have their diabetes medication at hand. Here I am sharing the covers of our 8 issues from our magazine, DiaLeb Review, which is definitely free of charge for everyone, and bilingual, English, Arabic. about 100 pages of very important information. For you to contact us, we are on all the social media portals. Feel free to contact us at any time. And thank you for your attention. And now it is definitely my pleasure to present Professor Andrew Bolton. Professor Andrew Bolton is a professor of medicine at the University of Manchester with a special interest in diabetes and its complications, and consultant physician at Manchester Royal Infirmary. He is the current president of the International Diabetes Federation. And the chairman of the European Alliance for Diabetes Research, EURADIA, since 2017. He has published over 550 peer-reviewed papers and is currently on the editorial board of a number of diabetes journals. He was the first awardee of the International Award into Diabetic Food Research. He has also received several other awards from different diabetes associations, including the American Diabetes Associations in 2008, Harold Rifkin Award for Distinguished International Service in the Cause of Diabetes. Professor Bolton is a member of several committees and professional bodies, including the British, European, and American Diabetes Associations and the Association of Physicians of Great Britain and Northern Ireland. Professor Bolton, the floor is yours.
Thank you very much, Jackie, and bonsoir mes amis au Liban. But I will speak in English and not French, even though I have spoken in French before. And even to Morocco, La Maroc, il y a 10 jours. So I'm going to talk briefly about the challenges that we're facing right now. Here are some global statistics that you are, I'm sure, familiar with. And that is that we have approximately 500 million cases across the world right now. In the UK, probably 5 million people. But our good friend, Abdul Basit, and the immediate past chair of MENA region of IDF, published this paper quite recently that 26.4% of adults in Pakistan have diabetes. And in many other Middle Eastern countries, as you know, it is very high. Here are the data from Abdul Basit and colleagues with Samad Shera, the late Samad Shera, who was really the father of diabetes in this region and the mentor and advisor to many of us, including me. This was a population-based study, as I said, probably more than 45 million people in Pakistan with diabetes today. Here's a slightly older study from Egypt, which was then having the 9th highest prevalence globally. It's still very high. And this reported that the prevalence of diabetes in Egypt had doubled or tripled in the last 2 decades. And the same in type 1 diabetes. The prevalence in Egypt, probably 15 to 16%. These are very high. And if you look at this map, which you'll be familiar with, which is the publication from Busan last year, just under a year ago, and you see here, Middle East, North Africa, the projected rise nearly 100% in the years up till 2045. And this is going to be the second highest rise across the world, with the exception of sub-Saharan Africa. It was a former president of IDF, our friend Professor Paul Zimmet from Melbourne, Australia, that talked about the biggest epidemic in human history, diabesity. And currently, it's an underrated global public health issue. We have to look out of the box, think out of the box, not just traditional risk factors. What about maternal and child health? So we have a war. We have a war against diabetes. And of course, in any war, there are going to be battles, which we're fighting. All of us are fighting on behalf of diabetes, people with diabetes across the world, local, national, regional, and global. So far, the summary is that we have an urgent global need for policies that promote the prevention, the early diagnosis and effective management of all diabetes, but particularly type 2. And the messages for our governments across the world, wherever we are, is that we cannot afford to ignore diabetes as the human and economic costs are too great. Diabetes consumes a large amount of national healthcare budgets. In some developing countries, it's as high as 40%. And a large part of this is due to the late complications, which should be preventable. A few years ago, I was lucky enough to share the stage with Sri Narendra Modi, Prime Minister of India. And at this stage in Bangalore, he got up to an audience of more than 10,000, and he said the biggest threat to the health of India is no longer infectious diseases like malaria, tuberculosis. He said it's non-communicable diseases like diabetes. And he was absolutely right. I told him, you're absolutely right. But what worries us all now in diabetes is that this awful pandemic of COVID-19 is going to swing the pendulum back to more support for infectious diseases at the cost of diabetes and other non-communicable diseases. This was in the Sunday newspaper, the Sunday Times in UK last month. A patient with diabetes writing this, he had lost a leg. Cancer I thought was serious. I knew heart disease was serious, but diabetes did not feel serious at all. And that's the problem. Diabetes can be silent in its presentation. It can present with late complications because it's gone unrecognized, and people don't take it seriously. Oh gosh, cancer, that's terrible. How are you? Are you all right? Can I do something? Diabetes, oh, that's just a touch of sugar, don't worry about it. My grandmother had it, she was 90. That's the attitude we have to change. Because in its most advanced forms, diabetes is more fatal than cancer. This is our study because my area is late complications. And I like to see patients early, and I've got patients in my diabetes renal clinic I've been seeing for 30 years, and I've halted progression of their renal disease, and they've still got relatively normal renal function, keeping them away from end stage like you see on this slide. This was a paper we published years ago, following a lot of patients on dialysis as a consequence of end stage renal disease due to diabetes. The mortality is horrendous. Look at this. If patients had lost part of a limb because of diabetic foot disease and were on dialysis, 3 out of 4 were dead within 2 years. I would put it to you, this is worse than almost every cancer, apart from perhaps pancreas and lung. And therefore, we need to take diabetes seriously. This is entirely preventable. It doesn't need to happen. I remember as a young fellow, when I had black hair in about 1981, speaking to the Juvenile Diabetes Foundation meeting as a young scholar. I was invited to speak. And many parents said, we appreciate what you do, but we have young children with diabetes. We can't listen to your talk, which is sad because most of what I'm saying is entirely preventable, and that's the message. So 21st diabetology, prevention is the key. Blood sugar control should be up to date, accessible and consistent. And diabetes complications, neuropathy, eyes, kidneys, this can be silent. These can all be silent unless we look for them. And therefore, screening is essential. And that's the message. And I agree that nurses are a key part of the team, and I'll return to that. A few slides about diabetes and COVID. This is a nice review from Liz Selvin, an epidemiologist I know at Johns Hopkins in Baltimore. And this is looking, just published in Diabetes Care, looking at some questions about diabetes. Is diabetes a risk factor for COVID? In actual fact, there isn't strong evidence that it actually is, which is good news. So it doesn't appear that diabetes itself is a risk factor. But if you have diabetes and get COVID and don't look after yourself, then the outlook is not as good. So that's why prevention is so important. Because if we get the control right, make patients feel more relaxed, not anxious, and really watch obesity, those who have good control and are not obese do much better. So we can do so much, and that's the message of my talk. The role of obesity is an important risk factor in progression and even death in COVID. May relate to ventilation, reduced residual lung capacity, whatever. That's still a fact. Here are some lessons for diabetes. In the UK, 1/3 of all hospital deaths in intensive care are in people with diabetes. Age, poorer blood glucose control, having other complications, heart disease, kidney disease, blood pressure, are all predictors of poor outcome. So it's probably the the other conditions rather than diabetes itself. So diabetes needs the attention it deserves in this population. Oh, my slides have gone. That's interesting. My slides have suddenly disappeared. I'll go back. So there are real world lessons, and this is Matt Riddle, a good friend of mine, the senior editor and editor-in-chief of Diabetes Care, and we work together. This is his review of what can we learn from published reports about people with diabetes. As I said, diabetes doesn't increase the likelihood of getting infection. Young people don't seem to do badly. Young people with diabetes don't generally need to go to hospital. They do fine. But diabetes is not shown to increase the likelihood of infection, but progression to more diseases, if they get it, is important. As I've said, diabetes, obesity, ethnicity, late complications. So we need to support vulnerable people with diabetes throughout this epidemic. So the threats, we've asked many of our patients to shield during this. In other words, if they've had a transplant, or if they're on immunosuppressive therapy, or they've got other complications, they're at greater risk. So they've stayed at home. This can induce poor diet, lack of exercise, poor blood sugar control. But we mustn't underestimate the psychological impact. It's very depressing to sit at home all the time, and they become anxious. And rightly, these people are frightened of going to the hospital. In my diabetes clinic, in the hospital clinic, during this time, about half of them don't attend. So I moved my foot clinic outside of the hospital, and 100% attended. I've seen 30 patients this morning. So we are frightened that there might be a tsunami of complications after all this. But there are opportunities: telemedicine, digital education, improvement in inpatient service, and enforced service redesign. So the threats are the cancellation of routine clinics, which has happened during the lockdown. Medicines, supply chains, which I know you've been familiar with in Lebanon, especially in Syria. Suspension of routine investigations and non-emergency surgery, and transplant surgery was suspended for a while. So the worry is a double whammy. Clinical research is swinging back to infectious diseases, loss of income from major diabetes associations. And clinical diabetes care is suffering throughout the pandemic, and fear of hospital clinics. And rightly so, because obviously the hospitals have many patients with COVID, and people are right to be afraid, is leading to poor attendance. So we need to attend to these factors. But there are some potential solutions and good things. Collaboration between stakeholders in non-communicable diseases. We're working with WHO, with Global Coalition for Circulatory Health, Non-Communicable Diseases Association, and others. Increasing global awareness of diabetes as a serious life-threatening condition is vital. And the message to politicians re the epidemic should talk about the cost of diabetes. That's what makes politicians listen. Lastly, as we've said, nurses are key. And I think the nurse should be an equal partner in the diabetes team. Not when I used to go to Eastern Europe, just after the end of the Soviet times, and the nurse was the person that brought the tea and the vodka to the doctors. I took a nurse with me, and she grabbed hold of the professor and took him, "You go and get the tea." That's how it should be. Nurses are key. Nurses make a difference. So we have made the nurse in diabetes part of World Diabetes Year, especially World Diabetes Month right now, just as WHO have, because it's 200 years since the birth of Florence Nightingale, the founder of modern nursing. Nurses account for a large number of the global health workforce. They represent a shortage in healthcare workers. They play a key role in preventing, diagnosing, and managing. And they're often the key link between the person with diabetes and other healthcare professionals. So what I want now is a global call for action to increase awareness of diabetes as a potentially preventable and eminently treatable disorder. So I'll leave you with a book, a quotation from the Old Testament, the book of Ecclesiasticus. It says, before you speak, learn. Well, I hope that's true for me, but before you fall ill, take care of your health. And that's such an important message for people with diabetes. Look after yourself and you should do okay. Shukran, merci bien.
Thank you so much, Professor Bolton, for this really interesting presentation. Thank you for your time, for all the important messages you gave us throughout this presentation. It is now my pleasure to present to you Dr. Mohammed Sandid, who is a professor of medicine and endocrinology at the Lebanese University. He holds a degree in endocrinology and diabetology from the University of Paris 6. He was the manager of the National Diabetes Program at the Ministry of Health in Lebanon. He is the president of the Lebanese Diabetes Society and a member of several societies and associations, including the Lebanese Endocrinology Society, the American Diabetes Association, the Pan-Arab Association, the Chronic Care Center in Lebanon, and others. He is also the founder and member of the Arab Association of Diabetes and Endocrinology registered in Jordan. Dr. Sandid is currently the chair-elect for the International Diabetes Federation, IDF, in the MENA region. And let me say, it is the first time Lebanon is occupying the chair seat at the IDF in the MENA region. It is sure a reason for us all to be proud. Dr. Sandid, the floor is yours.
Thank you, Dr. Jackie, for your nice introduction. Dear President, Professor Bolton, dear attendees, organizer, participant, and thank you for inviting me today. In the few minutes, I will be summarizing diabetes challenges in MENA region. You see here the dramatically increasing number in diabetes. In 20 years, the number of diabetics has tripled. If we're not able to act seriously now, this number lead to 700 million by 2045. That's why we can call diabetes now as a tsunami. This is a global prevalence of diabetes. Here we will discuss in worldwide, diabetes is increased by 51%, being 463 million in 2019 and reaching 7 million as predicted in 2045. On the other hand, in MENA, diabetes will dramatically increase by 96%, being 55 million in 2019, reaching 108 million in 2045. In this slide, IDF, International Diabetes Federation, a vibrant federation, includes 230 plus members across 170 countries, divided into 7 regional offices. MENA region is one of them. In this slide, we will see the prevalence of diabetes in MENA region. We can see that the regional prevalence in 219 is 12.8% and expected to increase to 15.7% in 2045. In addition, the number of deaths due to diabetes is 419K in 2019, and the proportion of undiagnosed diabetes is 45%. In this slide also, we see how the number of people with impaired glucose tolerance will increase from 35 million to 64 million. And we have the number of children in adolescent with type 1 diabetes being 149K, and of those newly diagnosed, 20K. In the slide, the prevalence of hyperglycemia and pregnancy in MENA region, 1 in 9 live births are affected by hyperglycemia and pregnancy. This is the MENA region map, includes 21 countries as seen above. It includes all Arab countries. In addition to Iran, Pakistan, Afghanistan, the prevalence is different between each country. You can see here the 21 countries and the prevalence of each country. The lowest prevalence is in Yemen with 5.3%, and the highest in Sudan with 22%, and with Lebanon being in the middle with 11.2%. Here is a more detailed slide to show you the top 5 countries with the highest prevalence: Pakistan, Egypt, Iran, Saudi Arabia, and Sudan. In this graph, we can see that over the past 20 years, how the diabetes prevalence in the MENA region has increased from 7.7% in 2000 to 12.8% in 2019, having 55 million people with diabetes. In Lebanon, unfortunately, the number of prevalence is different between resources and are between 7.9% and 11.2%. And the reason is that most studies are not representative. That's why in Lebanon, we need to have representative study to have more accurate numbers. And from here, I hope to unify the effort to have an exact and accurate number. COVID-19 in people living with diabetes in MENA. The characteristic of our MENA region: large geographic area, marked discrepancy among its countries is economic status, population size, infrastructure, and culture habits. Very high prevalence of diabetes. The MENA region has the biggest number of human disasters, civil wars, local conflicts, poverty, displacement, refugees, instability, and fragility. What is the difficulties? Some countries are overcrowded and packed with refugee camps, lacking appropriate sanitation services, increasing the virus transmission. Due to the economic situation in some MENA countries, the supply of insulin and medical equipment is limited. The sanction of some countries create difficulties in providing enough insulin to the population. The recent event in Lebanon, in addition to the port explosion that took place in Beirut, also slowed down the supply chain of insulin and oral anti-diabetic drugs. We have an opportunity in MENA region, in spite of their limited human, medical, and economic resources. Countries of the MENA region look to be not badly affected as other regions. This is figures about our MENA compared to world population. We have in May 8% decrease in October to 6.8, deaths 3.3%. In October, 6.3%. In USA, 327 million versus Egypt plus Pakistan, 317 million. Mortality in USA, 237,000. Egypt plus Pakistan, 13,000. And interaction between COVID-19 and diabetes, there are interaction is both the direction. Diabetes can worsen the COVID-19 outcome, pathophysiological. COVID-19 can lead to diabetes worsening and newly appearing. So due to the increase of diabetes prevalence in our region, we are urged to act now and apply the IDF recommendation to control the situation, focusing on education, prevention, access and care, and epidemiology and public health. Here, here, the results of one of studies in some countries in the MENA showed that 30% of diabetic patients had never received any diabetes education, and this explains the high rate diabetics prevalence in our region. On the occasion of the World Diabetes Day slogan, nurses make the difference. I want to congratulate the nurses body for the wonderful role they play in these difficult circumstances. It is imperative to mention the effort made by the MENA members, especially the diligent work of the committees to implement practical steps that reduce the burden of diabetes in our region. Finally, I always remember the saying I heard during the endorsement of the Diabetes United Nations resolution in New York: when people work with integrity and commitment for a noble cause, something the world will listen. Thank you for your attention.
Thank you so much, Dr. Sandid. Really enriching presentation. And regarding what you mentioned, we are definitely more than willing to join efforts with you to make updated statistics in Lebanon, because we need them. And probably with you being chair-elect now and soon the chair of the MENA region, we can do a lot with the Ministry of Public Health and update our statistics and have the real numbers. Thank you so much. Allow me now to start with who's going to lead our first panel for today related to diabetes update and challenges, Dr. Judith Scaf. As you see, we did not put any moderator. She is a very professional doctor, and she is endocrinologist, studied medicine at the St. Joseph University of Beirut, and graduated in 2011 as medical doctor. She did her residency at Hôtel Dieu de France, where she received her diploma of international medicine from St. Joseph University of Beirut in 2015. She then graduated from Sorbonne University with a diploma of endocrinology and diabetes. She also earned a subspecialty in pediatrics and transition endocrinology from Sorbonne University in Paris. She is currently an active member of the Board of Advisors of the Middle East Eating Disorder Association's MIDA. She is currently specializing in the psychology of obesity from the British Psychological Society and the National Center for Eating Disorders in London. She is a practitioner at Tal Shiha and Khouri hospitals in Zahle, at Bellevue Medical Center in Mansouriye, and at Rosaire Hospital in Ashrafiyeh. Dr. Scaf is a member of the scientific committee at DiaLeb. And she's still studying, imagine that. Thank you, Dr. Judith, for being with us. The floor is yours to lead your panel.
Thank you, Jackie, and welcome everyone. And thank you for being here with us today. In our first panel, we will be having an overview on the updates and the challenges of diabetes. Before I start by introducing our first speaker, let me tell you that we will be taking your questions. So please, there is a box of Q&A at the bottom of your screen. If you have any question, please drop them there. We will be answering them at the end of the panel. And please kindly mention the doctor you are asking the question, you're addressing the question to, so it will be easier for us to address this question. In our first talk, Dr. Nakhour will be joining us. Let me introduce her a bit. Dr. Nakhour graduated as an MD from the Lebanese University in 2009, and then specialized in internal medicine and in endocrinology at the AUB University. She obtained a master's degree in health research from AUB in 2018. She is a consultant endocrinologist at Kasserine Medical Center, Centre Hospitalier du Nord, and Hôpital de Secours in Lebanon. She is actively involved in teaching and research in collaboration with the Holy Spirit University of Kastik and the American University of Beirut. Dr. Nakhour will be talking about the treatment and technology updates in type 2 diabetes in 2020. Dr. Nakhour, welcome, and the floor is yours.
Thank you, Dr. for the kind introduction. I'm so delighted to be with you tonight with this awesome number of attendees that I have never seen, at least in the webinars I have provided. I'm here tonight to give you the scientific part, probably, of the diabetes updates. I'm going to start with a small story. Yesterday, actually, a patient came to my clinic with uncontrolled diabetes and with long-standing history of diabetes, of type 2 diabetes, an old man. He told he's on insulin and on metformin only. He asked me to give him Janumet. He told me, please give me this new drug. I looked at him. I told him I will. So actually, Janumet, mister, is no more a new drug. And the diabetes drugs are moving so fast in the last decade in the research and in the technology. I don't know if now the COVID and the research will move toward the communicable disease, where all the focus was before the COVID on non-communicable disease and especially on diabetes. So it's always nice to give updates, specifically with this fast progressing diabetes treatment. And I will be summarizing to you tonight the diabetes treatment that we have so far. This is the outline of my presentation. I will start with a small introduction on prevalence and pathophysiology. I will talk a little bit about the older therapies and then introduce to you the newer therapies and a little bit about diabetes technology in the very short time I'm allowed to talk with. This slide, shared by Dr. Sandid also, the worldwide diabetes prevalence. We always say that diabetes prevalence is increasing worldwide, and we always say that every 10 years, diabetes is increasing or doubling the incidence of diabetes. We were using this slide actually from many years ago, and we're still saying that diabetes prevalence is increasing. We're still saying that diabetes prevalence is doubling every 10 years. And this is the projection, as Dr. Sandit have shown us, to 2040, where there's expected 642 million people to be affected with diabetes. In 2015, 1 in 11 adults has diabetes, and the projection to 2040 that 1 in 10 adults will have diabetes. And this is really a global emergency, where about 12% of the global health expenditure before COVID is spent on diabetes. That's why we need really to focus on every update and to keep diabetes under control. I actually made this slide. It's a very interesting slide for me that I made. It's the diabetes prevalence since very, very long time in Lebanon. It started in 1969, and this is the according to the study. It's really variable according to what's the definition of diabetes taken in the studies. Is it by glucose? Is it by history? Is it by questionnaire? So we don't really have a unified study that can give us the real prevalence of diabetes in Lebanon. But in the last decade, the diabetes in adults varied between 15.8% in 2005, and it decreased a little bit in adults. The study in 2005 by Herbli et al. Was actually in people above 40 years of old. The others were in the adult population. And as Dr. Sandit said, we probably need a unified diabetes prevalence in Lebanon, but it can give us an idea. There are several parameters that impact type 2 diabetes pathophysiology, and it's always nice to review them with you. This is the ominous octet of the diabetes pathophysiology, and those are the mechanisms leading to hyperglycemia in diabetes. The most important mechanism is the decreased insulin secretion from the beta cells from the pancreas and the increased glucagon secretion by the alpha cells in the pancreas. Also, we have the increased hepatic glucose production, increased lipolysis, impaired appetite regulation, decreased incretin effect, increased glucose reabsorption from the kidneys, and decreased glucose uptake from peripheral tissues, specifically the muscles. And all of these are leading to the pathophysiology of diabetes and where therapies need to tackle to improve diabetes control. Not only this, but these pathophysiology are starting very early, even before the diabetes diagnosis. In the impaired glucose tolerance phase, 4 to 7 years before the appearance of diabetes, the pathophysiology of diabetes starts. And this is very critical to discuss with the patient. At the time we diagnose diabetes, we are already in the process of developing the microvascular and macrovascular complications. At the time of diagnosis of diabetes, we almost lost 50% of beta cell function. And this is why we need to tell the patient that it's a chronic disease, it's actually not curable, but it should be under control. And I'm gonna summarize to you all the treatments to bring type 2 diabetes to control that are available nowadays. So as I said, those are the target organs for diabetes therapy, and each of the therapy available are targeting one or many of the pathways of the amino octet I have shown you. For example, metformin, TZDs, and the sulfonylureas, which are the old drugs, are tackling mainly peripheral tissues like the muscles or the SU, the pancreas, where they lead to increased insulin release. While the newer therapy, they are actually better in the way where they tackle more than one pathway in the amino octet, and I will be detailing them one by one. This is a table where I summarized the older diabetes therapy that, of course, are still used. Of course, metformin, for example, is still the standard of care for diabetes. It's the still first-line therapy of diabetes. Why is that? Because it's a 45-year-old drug with very good efficacy on A1C control, long-term safety, low risk of hypoglycemia. It has reduced cardiovascular risk for patients, and the cost is very low. So you know that guidelines come from cost effectiveness. And that's why, until now, metformin is the first-line treatment for diabetes. We have the sulfonylurea. They are very efficacious, but they have risk of hypoglycemia and weight gain, and they have conflicting results on safety. We have the pioglitazone or TZDs, also very efficacious. They have some heart failure risk. That's why we should be careful in using them in patients with heart failure, but they are at low risk of hypoglycemia. So this is the old therapies. What about the new therapies? So Janumet is one of the DPP-4 inhibitors my patient asked about. It's actually a 14-year-old drug nowadays. Just to summarize for you, what's DPP-4? DPP-4 inhibitors. So this is the mechanism of actions of DPP-4. When we eat, the intestine secretes the active GLP-1, which is a late research that came just 10 years ago. It should be from long time. It's the pathophysiology of diabetes. So the active GLP-1 that our body has, secreted by the intestines when we eat. GLP-1 actually acts on the pancreas to make the pancreas secrete in a glucose dependent, only if the glucose is high, insulin, where insulin is used by the peripheral tissue to increase glucose utilization. It also decreases the glucagon secretion, so it suppresses and decreases hepatic glucose production, and this improves overall glucose control. But this native GLP-1 is directly inactivated by the DPP-4 enzyme. So the class of therapy, which is the DPP-4 inhibitors, inhibit this enzyme, thus leaving our active GLP-1 higher and thus benefiting on glucose control. It binds to the DPP-4 just like the key. It's a substrate-like binding. It's one example of vildagliptin where it binds to the DPP-4, inhibit the DPP-4, and then the enzyme will not work, and then GLP-1 will stay in the body and we will benefit. This is the DPP-4 inhibitors available in the market and that we are using and benefit. What about, so very efficacious in diabetes control, and they are cardiovascularly safe. This is one of the trials of DPP-4, and all of them are almost similar, where they show safety in terms of cardiac protection. So they are safe, they are neutral, not protective, but will not make any cardiac events. Just a small signal went with one of the molecule, which is saxagliptin, on heart failure, but it was not really a focus for the study. So it's not really clinically significant, but there's a box warning on the saxagliptin in the use of patients with heart failure. Otherwise, efficacious, neutral on the heart and neutral on the weight. Then, came the GLP-1. GLP-1 is the mimicker of our native GLP-1. Those are the agonists. So this is the same, but the GLP-1 are just mimicking our active GLP-1, and they are very efficacious. Actually, they tackle many of the ominous octet pathways by, in the pancreas, increasing beta cell function, at the liver, decreasing hepatic glucose production, decrease lipotoxicity, and the brain, decrease body weight, decrease food intake, increase satiety, and many others. And that's why this is a family with very good efficacy. We have many available. We have some short acting, once a day acting, and we have also the more sophisticated GLP-1, which are the very efficacious once weekly GLP-1 that we are using, and many of you are familiar with this therapy. What are the benefits? They actually are very efficacious, as I said, efficacy on diabetes control, even compared to insulin. They are very efficacious on weight loss, and up to 2 to 6 kilogram weight loss in the study, variable according to the study and the type of GLP-1. And actually, and the surprise was that they have cardiovascular benefits, not only safe, but also benefit mainly in MACE, major cardiovascular event reduction. The last one of the newer therapy are the SGLT2 inhibitors. The SGLT2 inhibitors, they inhibit the SGLT2, the sodium glucose transporter, and thus they decrease glucose reabsorption, and glucose is excreted in the urine. And in this way, we get rid of the glucose in the urine. Very efficacious, very new family to the market. It's actually the newest. Those are the names available, and also they have cardiovascular safety trials. So in addition to efficacy on diabetes control, they have cardiovascular benefits. But also, and because we're losing calories in the urine, they lead to some weight loss, less than the GLP-1, but also we need this weight loss in our type 2 diabetes patient. So they are very efficacious. And the other surprise was that this family have heart failure protection. And I summarized for you. I don't want you to go into the details, but if you can see, those are the three, and we have a new study on this family of SGLT2. And if you see the last line, you can see that there are robust reduction with this family in hospitalization from heart failure. And this will lead to the use of these patients in diabetics with heart failure. And even nowadays, using those families even in patients with heart failure and without diabetes. And this is because of those studies that get to this beautiful surprise. They have some side effects, actually. I don't want to go into details, but mainly because they excrete in urine, they excrete the glucose, they can get some genital tract infection that are bothering, and some UTIs. And we need to be careful in this matter. So I summarized to you the three new family. This is the insulin therapy. I'm not going to go into details, just to show you that we went to the analog, and there's a complete history of insulin that will be following my talk addressed to you. So we have the insulins and we have the combination of insulins. And this is the portfolio of diabetes therapy. The good is to use any of the diabetes drug according to the physician, and individualized therapy according to what the patient needs. And last, I will end my talk with a few slides about diabetes technology. Nowadays, diabetes management is not only about the anti-hyperglycemic, but also it's more sophisticated, and the world is changing. It's changing from using HbA1c as the gold standard, and it's still the gold standard of diabetes care, to using time in range for diabetes. So if you see the first graph, you can see that there is fluctuation in diabetes, but probably the A1C will not give you this image, while the time in range, the continuous glucose monitoring, will give you this image. And the world nowadays is moving toward detection of the time in range. And how to detect the time in range? This is a graph showing the continuous glucose monitoring. So you can say every 5 minutes have a reading of glucose and get time in range, time how much the patient is in range of glucose control, and to get into diabetes control. How we can use it, or how we can get the time in range? It's through the continuous glucose monitoring device, and we have some available. And I think in the MENA region, we have a lot of them available. We have the Freestyle. It's a continuous glucose monitoring. We have the Dexcom, real-time continuous glucose monitoring, and others by Medtronic and Senseonics. Those are very important systems, and the world is moving toward them because they really give you an image other than A1C on diabetes control. This is all for the benefit of the patient to get on his target level of control. From the CGM, you can get actually a report on the time in range. And if you can see the green bar is the time in range. And this should be 70% and above, where the patient should be between 70 to 180 during the day of glucose in range. And this is very important. We're using more and more, mainly in patients with insulin, mainly in patients with type 1, and nowadays moving for pregnancy and etc. So I've summarized to you the diabetes technology and of course the diabetes medications. So as my take-home messages, first, diabetes therapies are in rapid evolution and we need to know about them. The most important thing is to get patient on his target control regardless of what medication we use. We should individualize therapy to each patient according to many factors, including age, diabetes duration, and concomitant disease. And lastly, we should use technology to lower hypoglycemia risk and to improve diabetes outcome in every diabetic patient. And thank you.
Thank you so much, Dr. Nakhour, for this exhaustive review about the therapy in type 2 diabetes. Please stay with us. We will have questions at the end of the panel. Okay. And now let's move to our second speaker, Dr. Marwan Zaghbi. Dr. Marwan is a family medicine specialist from St. Joseph University in Beirut, in Lebanon, with competence in liaison psychiatry. He holds a diploma in epidemiology and biostatistics and a diploma in medical education, in addition to a postgraduate diploma in diabetes from Leicester University. He is a member of DiaLeb's scientific committee, a member of the Lebanese Order of Physicians Council, and a member of the Lebanese Society of Family Medicine. Dr. Zaghbi is also a member of the scientific and organizing committees of the annual conference of the Lebanese Society of Family Medicine. Dr. Zaghbi is the founder of the Lebanese Research Forum. He is an author of several articles. His research interests include community mental health, diabetes and hyperlipidemia, medical education, and public health. Dr. Marwan Zaghbi participated as an investigator, country leader, and a global panel member in Lyra Prime trial, which compares the efficacy of liraglutide versus oral anti-diabetic drugs in controlling glycemia in patients with type 2 diabetes. Tonight, Dr. Zaghbi will be telling us about the history of insulin. Dr. Zaghbi, we are all ears. Just unmute yourself, doctor.
Thank you. Thank you for the introduction. And I was saying that I'm very happy to be with you tonight, sharing this unique experience of telling the story of insulin. So now we are at 100 years after the creation or the invention of insulin. We have to celebrate because it really changed a lot of things. And it is a real nice story to tell. I usually don't like the historical story presentations, but this one is really fascinating, so I hope you will enjoy it. So I will start by telling you about the objectives. So the objectives of this presentation are to recognize the main achievements leading to today's insulin and to acknowledge the positive impact on patients' lives. The first mention of a disease like diabetes was done by Apollonius of Memphis And he told us about something meaning to go through or to have a lot of urine. The term diabetes was probably first used by the Greek physician Demetrius of Apamea, from the Greek word which is diabetes, so for those who don't know Greek. And then we have from Galenus to Avicenna, the Roman physician Claudius Galenus used the term diarrhea urinosa to talk about this increased urine output in patients with diabetes, or it was the dipsatos, which has the same meaning. And then Avicenna, the well-known Arab philosopher and scientist, talked about his book, his famous book, The Canon of Medicine, and he described abnormal appetite and gangrene in patients with diabetes. And then we had Willis. Willis described the diabetes as the pissing evil. The term diabetes mellitus was introduced in 1674 by Thomas Willis. He was a British physician, and he differentiated for the first time the diabetes mellitus from diabetes insipidus, referring to the sweetness of urine in diabetic patients. And then we have Dobson, who discovered the secret of the sweetness in urine for patients with diabetes, and it was in 1776 a physician from Liverpool who discovered that this was due to sugar. He published this finding in the Medical Observations and Inquiries. And from our recent time, we had Gerald Reaven, who is the father of the insulin resistance, who described the syndrome X. I remember when I was a resident, we called it syndrome X, and now we talk about the metabolic syndrome. And this was first done in 1988 during what we call the Banting lecture at the ADA. I'm telling you this just to tell you a little bit of history about metabolic syndrome and how it evolved and how we discovered the resistance to insulin, and to tell you that Banting is still till today one of the famous figures in diabetes, and we have a lecture in ADA every year called the Banting lecture. So what was done in the pre-insulin era? We had a lot of efforts to control diabetes, but we had a lot of bizarre pharmacologic treatments, like the use of opium, like the use of bizarre diet habits. And sometimes we had the conviction that diabetic patients should eat extra portions for compensating their metabolic impairment. So this was before the era of insulin. And then we had this big debate through hundreds of years on how to treat patients with diabetes with diet. So in 1706, John Rollo had successfully treated a patient with dietary restriction. And then in 1850, a French physician called Pierre-Adolphe Piori prescribed hypercaloric diets for counteracting the urinary loss of calories. So a lot of confusion was here before insulin and before the discoveries of Banting and all the others. And then we had this famous Bouchardat. He was French, he was pharmacist and hygienist, and he considered that treating diabetes must be with dietary restriction, because he observed an improvement in patients with diabetes during the German siege of Paris in 1870. And his school, which included other doctors, became famous for advising sugar-free diets known as Bouchardat treatment. The starvation took its was more used also by others in America, like the famous Elliot Proctor Joslin. And Elliot Proctor Joslin is the founder of Joslin Diabetes, which exists till today. And he was offering specialized services to diabetic patients and was a fervent advocate of severe prolonged fasting and of undernutrition to cure diabetes. So this is the history of diabetes, and then I will go to the discovery of this fascinating hormone, which is insulin. Paul Langerhans, in 1869, was a student. He was a medical student, and he was pathologist, physiologist, and biologist, but he could discover his discovery when he was a medical student, and he was studying the structure of the pancreas under the microscope. when he noticed something like islets, and he described them, and they are called islets of Langerhans till today. And then we had Schaffer. Schaffer was from London, and in 1910 he talked about the secretion of the pancreatic island that has the capability to control glucose metabolism. And he termed this secretion insulin because it is coming from the island, from insula, and with reference to the Langerhans Islands. So, and then he was not the only one to talk about this, because another French histologist, Gustave Edouard Laguesse, has talked about the capability of the Langerhans Islands to secrete a substance capable of preventing the elimination of glucose through the urine. And then this has inspired Eugène Gley. Eugène Gley was a French physician, and he was working on this to test this hypothesis. And he took aqueous extract of the pancreas, and he administered them to diabetic pancreas. He induced diabetes in dogs by doing a pancreatectomy, and then he injected the aqueous extract of the pancreas into the dogs. And he noted that glycosuria was reduced and the symptoms of diabetes significantly improved. What did he do? Eugène Gley, after finishing these experiences, he wrote a report that he sealed with an envelope and handed over to the Société Française de Biologie in 1905. And he recommended that they do not open this envelope before his explicit request. So Gley no longer repeated his experiments because of the World Wide War, the First World War. And in 1921, when Banting and Best made their discovery, and it was running all over the world and talking about this discovery, he ordered to open his letter, and he realized that he has discovered insulin without knowing it was insulin. So what were the people needs before insulin era? Why do we need insulin? Because patients with diabetes, especially with type 1 diabetes, were dying in few months after the discovery of the diagnosis because they didn't have any treatment, and you saw how treatment was suggested in an anarchic way. So everyone with type 1 diabetes had to die, and this was the first need. We need to survive. And this is how Banting this is why Banting tried to discover what he discovered. So what did he want? Banting wanted to overcome one difficulty encountered by all scholars who wanted to separate the extract of the Langerhans Islands, because we talked about this substance, this miraculous substance that would be helpful, but we couldn't extract it from the pancreas because they couldn't separate it from the exocrine secretions of the pancreas. So Banting was a surgeon, he was an orthopedic surgeon, and he was Canadian, apparently. And his goal was to isolate the hormones secreted by the pancreatic islands. What did he do? He was reading one of Minkowski's papers, and Minkowski was one of those who talked about the secretions. And Minkowski thought that the secretions of the endocrine pancreas were made ineffective because of the activity of the exocrine pancreas on them. So he thought that they were breaking down the islet secretions, making it inefficacious when he is doing it and extracting the pancreas extract. So the idea was that the pancreas internal secretions, which regulates sugar in the bloodstream, might hold the key to the treatment of diabetes. And as a surgeon, he went into the arteries of the pancreas, and he could manage to get some arteries tied and closed, and that would lead to an atrophy of most of the pancreas, of the exocrine pancreas, while leaving the islets of Langerhans intact. So this is how he thought he could get this hormone without getting the exocrine secretions. So in 1921, he traveled to Toronto to explain this idea to MacLeod, MacLeod was a professor of physiology and he was holding a laboratory in Toronto. So he was asking him if he could use his lab to test his idea, and MacLeod agreed to let Banting use his lab and supplied him with 10 dogs at first on which to experiment, and the lab assistant called Charles Best. Charles Best has another funny story I will tell you about. And then MacLeod went to his vacation, and after he came back, he saw the progress of Banting work, and Best was assisting him, and he decided to let Banting continue his research and supplied him with more dogs, a bigger lab, and pointed out the flaws in his research. And where did we get? I will tell you about Charles Best before. Charles Best was a student, and he had to share the rotation with Banting with another student called Clark Noble. So Banting required only one lab assistant, and they had to do a coin flip, and Best was chosen. He had to do the first month and then shift with his partner. But unfortunately for Noble, Banting decided to keep Best for the entire summer. And then we have the intervention of another important one who was behind the scene for most of the time. He was called James Collip. James Collip used to work with them, and he is the one who worked a lot on the purification of the insulin extract, and we will see that he had a major role in the first experimentation on insulin. So these are the discoverers of insulin: Frederick Banting, John James MacLeod, Charles Best, and James Collip. Who was the first patient to receive insulin injection? His name is Leonard Thompson. He was dying at the Toronto General Hospital, a 14-year-old patient, and the extract of Banting was so impure, so he suffered a severe allergic reactions and abscess, and further injections were cancelled at the beginning. During the next days, Collip developed a second dose with purified extract, and Banting injected them again for Leonard Thompson, and the second injection was a real success, with the first time describing insulin injection for a human with good effect on eliminating the glycosuria and the signs of diabetes. And then we know that Leonard Thompson could survive for 13 more years, and he died from pneumonia because they didn't have antibiotics at that time. And then the experience was repeated, and then I can show you some testimonials from patients thanking Dr. Banting for giving them this miraculous hormone and curing them from diabetes. They could get active again, they could gain weight again and be active. One of the first medical doctors to receive the insulin was Joe Gilchrist, and he was the first adult to suffer insulin-induced hypoglycemia. He was at that time a diabetic. And here I show you the first publication done by Banting on insulin, and it was done on December 12, 1921, where they reported the results of the discovery of insulin to the American Society of Physiology. What did they do with the insulin? In 1922, Best managed to improve the techniques, and to the point where large quantities of insulin could be extracted on demand. Eli Lilly and company united with Banting, and they made a breakthrough and were able to produce large quantities. In 1923, a German laboratory began producing insulin following the manufacturing license issued by the Toronto Insulin Committee, and then it was all over Europe, and then it was in America, in Latin America, and Argentina in 1924. So here you see that the Nobel Prize was offered and given to Banting and MacLeod only, but in respect and to make honor to their colleagues, Banting decided to share with Best, and MacLeod decided to share his Nobel Prize with Kossip. And then emergent needs came out. The insulin that was produced by Banting was a short-acting insulin, and patients needed a longer-acting insulin. And here started the research in order to discover a way to make this insulin with longer period of activity. And the first one who succeeded in doing this was a physician called Hans Christian Hagedorn, and who in 1923 established the Nordisk Insulin Laboratorium. And then he produced a slowly absorbed insulin in Copenhagen by combining the hormone with a protein called protamine. And then in 1939 in Toronto, another David Scott created insulin protamine zinco complex whose glucose lowering effect lasted up to 48 hours. So you see, the first need was the survival, to die from diabetes. Then we started having more needs and more askings from the insulin production. And then in the 50s, we had the insulin Lante, Semilante, and Ultralante were developed. In Denmark, they found a method to combine recrystallization of insulin with chromatographic procedure to produce these slow insulin. But here I repeat, they were animal insulins, they were not human insulins. You can see that they were made from beef and pork, knowing that the first experience was on dogs, but then they shifted rapidly to beef and pork production. And then we had the Nobel Prizes cascade. In 1955, Frederick Sanger could establish the sequence of bovine insulin and the exact composition in terms of amino acids. And in 64, another woman, an English biochemist called Dorothy Mary Crowfoot Hodgkin, could determine the physical structure of insulin. And using this insulin, they discovered that the problems were about allergy, because these could induce allergies. And so patients who got allergy to insulin could not benefit from the treatment. And that's why we started thinking about how to make an insulin that would be more similar to the human insulin and that would cause less allergy. So in 1963 and 65, two researchers were able to synthesize insulin that was similar to the human insulin. And in 1975, a fully synthetic insulin was synthesized in the laboratories of Siba Jaigi in Basel. So Genentech RNA human insulin obtained on the 24th August 1978 from a combination of the two known chains of insulin individually expressed in E. coli. And then we had two big companies producing insulin. One was using a bacterial host, Eli Lilly, and the other one was using a yeast host to produce recombinant insulin that would be similar to human insulin. Here you can see we have the vector where we will inject a part of the DNA of the human insulin into the gene of the host, and then the host will start producing insulin. So in 1980, the recombinant DNA insulin was first tested in a sample of 17 non-diabetic volunteers in England. The first diabetic patient to be treated with these recombinant insulin was called Sandy Atherton, 37-year-old from Wichita, Kansas. And in 1982, other synthetic insulins, much less allergenic than animal insulins, became widely available to diabetic patients, such as Humulin, manufactured by Eli Lilly. Yet, we got another need. So now we have a good insulin, less allergy, long-acting, and we still need one thing. We need less variability, because the main target of treating patients with insulin is to mimic this normal physiologic insulin secretion, and with the goal of effective insulin therapy to be able to mimic to the maximum this normal insulin secretion in order to have a tight glycemic control without risk of hypoglycemia. And this is when, in the 80 to 90, we started thinking about the analog insulin, where we started producing them with a genetically modified form of insulin, where the amino acid sequence will be altered in order to optimize insulin absorption, distribution, metabolism, and excretion. In 1996, Eli Lilly introduced the first type of analog insulin called Lispro under the brand name of Humalog, and it is still now. Aspart then this was approved and released in 2000, while Glulizine in 2004. So I come here to the end of my presentation. What I want to say that from Banting's extract, which we didn't know what it was and how important it was, to today's analogs, insulin remains a medical marvel in the world of diabetes. The better is yet to come with new devices, with new possibilities and new ways of administration. We could dream about the oral insulin, which will be coming hopefully in the next years. We saw the inhaled insulin, we saw too many trials to improve this, and we hope that the better is yet to come. Thank you.
Thank you so much, Dr. Zouki, for this presentation. It's always interesting to look back at our history and the history of insulin to know how to continue from there. Again, I'm gonna remind everyone that if you have questions, don't forget to put them in the Q&A box, and we will be answering at the end of this panel. And now for our third talk for tonight, it's gonna be with Dr. Cosette Fakih. So Dr. Fakih is a lecturer and a clinical preceptor at the Lebanese American University. She is a licensed dietitian and holds an MS in human nutrition from the American University of Beirut and a PhD in health services research in dietetics from Maastricht University in the Netherlands. She started her career as a therapeutic dietitian and moved into being a dietetic training program coordinator, university instructor, and consultant dietitian. Dr. Fakih is a member of the scientific committee of at DiaLeb. Her research focuses on identifying effective dietary care practices in chronic diseases, particularly using mHealth tools. Her publications mainly focus on mHealth and dietetics and malnutrition practices in hospital settings. Tonight, Dr. Fakih will be talking about the nutrition therapy for adults with diabetes and what should the nurses know. Dr. Fakih, the floor is yours.
Thank you. Thank you for the very kind introduction. I think there's an echo in my sound.
No, I think it's fine.
Okay, great. Thank you for having me this evening. And it was very interesting to listen to the speakers that just spoke before me. I'm going to try as much as possible to relate to you nutrition therapy for adults with diabetes and specifically what I think nurses should know concerning this. So I'll, as much as possible and as briefly as possible, try to relay as much information as I manage to. I'd like to start by paying a tribute to nurses by sharing this very nice article written by a patient in the British Medical Journal, the patient's journey living with diabetes. And this patient came up with a few points that he believed doctors should be aware of whenever they are dealing with people with diabetes. And last but definitely not least point was that nurses specializing in diabetes, they're approachable, they are friendly, they are helpful, they have the time to talk, and they're easy to contact, to ask questions to. And that makes sense because, as you can see here, nurses manage to spend the most patient contact time as compared to other healthcare professionals. About 86% of the time, patients get to see nurses, whereas they only get to see their physician for 13% of the time, and other healthcare providers even less. So that definitely means that nurses play the biggest role when it comes to correcting misconceptions, when it comes to answering questions. And this is particular in the case of nutrition. Patients constantly ask nurses about questions about food, about their nutrition, and so on and so forth. So it's important that nurses have good knowledge in nutrition. And RNs have definitely been always placed at the forefront of educating and treating patients with diabetes. In fact, according to the national standards for diabetes self-management education, specifically Standard 5, instruction for self-management should be led either by nurses or dietitian. And diabetes self-management education is rather comprehensive and includes nutrition therapy at its core. So when nurses are expected to lead this kind of multidisciplinary education, they definitely need to have knowledge when it comes to nutrition. Let me get to the core of the presentation and talk a bit about the role of medical nutrition therapy in the management of diabetes. We know that there is strong evidence to support both the efficacy and the cost effectiveness of medical nutrition therapy as a component for the treatment of diabetes. And I'd like to highlight the goals of nutrition therapy. And these are 3 goals that I selected because I really think that it's important to know them and to keep them in the back of our mind every time we address people with diabetes. 1, a diet should definitely support the idea of healthy eating, a variety of the food, and the nutrient density of the food. And this is kind of what should be the case for everyone, and not just for people with diabetes, except with people with diabetes, this is a weapon that we can use to help improve all the cardiometabolic profiles and to improve HbA1c. The second very important goal of nutrition therapy is that we need to address every patient individually. We need to take into consideration their personal, their cultural preferences, their accessibility to food choices, their willingness to make changes in their diet. And last but definitely not least, this is my favorite one, it's right to enjoy food, and in no way should we be expecting patients with diabetes to absolutely stop eating foods that they enjoy, because there's nothing to support that principle. I want to show you the effectiveness of medical nutrition therapy by sharing this study. So in this study, there was a program, an MNT program that was intensive and that was individualized through multiple encounters with dietitians. And patients were allocated either to a treatment with medical nutrition therapy plus medications, and or the second treatment, which was MNT alone. Of course, allocation to either one of the two was based on their eligibility and their baseline HbA1c. And if we look at this, after the program, which lasted about 3 to 6 months, depending on the center, this was a multi-center study, we had patients here in graph A that with at baseline, we only had 21% of the people that had an HbA1c that is less than 7, which is the target that we expect our patients to reach. And then post-program, 67% had an HbA1c below 7. And even 1 year after follow-up, when we looked back at those patients who received this kind of intensive education, HbA1c below 7 was among 60% of the people. And it's very similar when we look at the MNT alone treatment arm. And we can see that although we started with a higher percentage of people with an HbA1c below 7, 93% had the target HbA1c at the end of the program. So changing dietary habits is a very powerful way of managing diabetes. But when thinking about nutrition therapy, it's important to create 2 separate mindsets. In the first mindset, we want to think about the effect of food as an immediate role player in blood sugar. So the food I eat is going to lead to a rise in blood sugar. In a second mindset, we want to think about the long-term impact of the foods that we eat on the overall outcome of people with diabetes. And as I keep talking, I really want you to keep those 2 concepts in your mind. Let me start with the immediate or short-term concept that's related to the relationship between food and between blood sugar. What we know is that the total amount of carbohydrates is the main determinant of blood sugar. What does this mean? It means the total amount of carbohydrates in a meal is going to kind of predict the blood sugar after that meal. And whenever we're thinking about it this way, our goal is to plan a consistent amount of carbohydrates across different meals. What does this mean? It means we provide our patients with the similar amount of carbohydrates at breakfast, then similar ones at lunch, similar ones in the evening, and we keep on replicating these quantities even across days. And what we know is that this is one of the most effective ways to manage blood sugar on a short-term basis. And to remind everyone where carbohydrates are found, although I know that this is quite common knowledge, we will find them in grains, so pasta, rice, cereals, We'll find them in fruits, in juices, in starchy vegetables, corn, potatoes, peas. And this is the one that I find interesting that people often miss, which is milk and yogurt. So milk and yogurt contain sugar called lactose, which is a disaccharide, and therefore it will cause a rise in blood sugar. Except when milk becomes cheese or lebne, for instance, the content of lactose of these foods becomes too little to actually significantly raise blood sugar. So what I'm trying to say is that if our patient snacks on a piece of cheese, there's not going to be an immediate impact on their blood sugar, at least not a relevant one. But if our patient decided to snack on a glass of milk, then there's going to be a rise in sugar that's relevant. So understanding the sources of carbohydrates in the diet are very important for us to help maintain adequate blood sugar fluctuations. The last two categories are beans and legumes. So beans like lentils, fava beans, broad beans, and so on. And the last one, which is everyone's favorite, are sweets. And we all definitely know that added sugar causes a rise in blood sugar. In no way am I trying to say that if we're saying the total amount of carbohydrate is the main determinant of blood sugar, that all carbohydrates are equal. And I will in a bit highlight this point. The quality of the carbohydrates is very important for the overall outcomes of our patients. Now let's start switching from this immediate blood sugar result as an outcome of the food that we eat to a longer term concept. What I want to highlight now are dietary patterns. Or what I mean by this is the combination of the different foods that we eat or the food groups that we consume, but that we consume today and tomorrow and after tomorrow and a week from now and so on and so forth, and probably for years. So these are really the collection of all of our dietary habits. And dietary patterns are very important for us when trying to understand both the effect on diabetes development, but at the same time on managing diabetes. I'm going to share with you a few dietary patterns and highlight some of them to show their impact on diabetes control. I'll start with the Mediterranean style, which I'm going to highlight tonight. So the Mediterranean style is at base a plant-based diet, has a lot of vegetables, a lot of beans, a lot of whole grains, that's the quality of the carbohydrates we're talking about, nuts and seeds, and a lot of fats that are plant-based in nature, so olive oil, nuts, and seeds. And this dietary pattern has been shown to both reduce the risk of diabetes, but also to help reduce the HbA1c, and among others, some additional cardiometabolic parameters. Another diet that also has a positive impact is the vegetarian or the vegan diet. To an extent or the other, this diet is either absolutely plant-based with no animal products whatsoever, and that's the vegan diet, or a bit less restrictive with some dairy products and some eggs in it. Also has been similarly shown to have good impacts on both risk of diabetes, A1C control, and LDL and HDL cholesterol. The last one are the low carbohydrate diets. Now, low carbohydrate diets are pretty popular when it comes to thinking about diabetes and diabetes control. In this dietary pattern that I'm showing here, however, the definition of low carbohydrates was used as an intake of carbohydrate that is between 26 and 45% of the total calories. Now, 45% of the total calories is actually a recommended intake for carbohydrates. So these were not low carbohydrates or very low carbohydrate diets that were restrictive enough to induce, let's say, ketosis. These were just on the lower ranges. They still allowed people to eat vegetables. They still allowed people to eat some fruits. They still allowed people to have carbohydrate sources, just that they decreased the intake to relevant amounts. And they had similar effects. Among these three that I highlighted, I want to focus more on the Mediterranean style diet. And the reason why I want to focus on it is because it resembles our eating patterns. And I am going to zoom down even further and talk about the Lebanese Mediterranean style diet. Why is the Mediterranean diet important? Well, first, because it's our cultural diet, and therefore we should always try to foster diets that are sustainable and local. But also because we know that people who consume a Mediterranean dietary pattern, so it's a long-term intake of this style of diets, their cumulative diabetes-free survival is better over a 5-year period of time as compared to a more westernized diet. And here we're looking at A and B in this graph that are the Mediterranean diet, either with extra virgin olive oil, which resembles ours, or nuts and seeds. And you can see that both A and B have a lower rate of diabetes as compared to C, which is a more westernized diet. And this Mediterranean diet is very close to home for us. So in a study that was done here in Lebanon, the authors identified 4 different dietary patterns among the Lebanese population. So they tried to understand what kinds of eating habits do Lebanese people have, and they classified them into 4 different dietary patterns. The first one, they called it the refined grains and desserts. And people in this dietary pattern that followed these eating habits, they consumed mainly refined cereals, so manouche, pizza, white breads, and desserts and added sugars. The second dietary pattern was the traditional Lebanese dietary pattern that included more plant-based foods, more monounsaturated fats coming from olive oil, more beans, and definitely less added sugar and less refined starches. The third category was the fast food. So they identified people who tended to overconsume fast food, and this was specifically called the Lebanese fast food. So shawarma, tawu, ready-made sandwiches. The last category was called the meat and alcohol. People who consumed alcohol on a regular basis, and their diet was basically based on meats, chicken, fish as well. But it was rather not plant-based, but animal-based. And this is what they found in the context of diabetes. To start with, they identified 2 dietary patterns as risk factors for diabetes. So the first one being refined grains and desserts, and the second one being the Lebanese fast food diet. But most interestingly, they found our traditional Lebanese diet, which is Mediterranean in nature, to be indirectly associated with the odds of diabetes. And people who consume this diet or this dietary pattern, because it's a long-term lifestyle, they had lower BMIs, they had a lower waist circumference, they consumed more monounsaturated fat that mainly came from olive oil, and more dietary fibers. And this is, when we say more dietary fibers, it means more plant-based foods, definitely. And this, our traditional diet, is one of the diets that seems to have protective effects on diabetes. And I am giving the example of Lebanon, but there are many Arab countries on the Mediterranean Sea, and many of us share common, if you want, foundations when it comes to eating habits. And going back to traditional eating habits is a very good technique in helping us achieve better diabetes control, but also in preventing diabetes. Now, there are multiple patterns that work. And I started by saying individualization is the key. So we're not supposed to force everyone to switch into traditional Mediterranean style diets. We need to look at each person, and we need to try what suits this person the most. But what we know is that despite multiple dietary patterns being able to fit or work for people with diabetes, there are certain common key factors that really seem to be like the secret recipe in making the change. The first one is an emphasis on non-starchy vegetables. People who consume more vegetables tend to have both better outcomes and also less risk of diabetes. Second, it's to minimize added sugar and refined grains. And I take this opportunity to remind everyone that refined grains, as time passes more and more, should not be really considered superior to added sugar. By refined grains, I mean white bread, I mean white rice and white pasta. And these are really refined to the extent that they lose most of the fiber that they contain. And therefore, their impact on blood sugar, both immediately but also on the long term, becomes similar to that of added sugar. So piece of cake, piece of white bread, I'm not sure. We should be careful about those choices. The last one is to choose whole foods and less processed foods. The more we eat fresh, whole foods, the less likely we are to develop diabetes, but also the better we are at managing people who already suffer from diabetes. So what I want to share with you here as a wrap up is the dietary guidelines for Lebanon, food-based dietary guidelines. And these were developed for the Lebanese population. And I don't want to take too much of your time because I know that I have a time limit. And I just want to show you the 4 14 messages that they relay, and I added a few just to really stress on them. First, enjoying and maintaining a healthy body weight. So we're not supposed to torture ourselves to get healthy body weights. We're supposed to still find a way to enjoy intrinsically the food that we eat, the food that we prepare, and yet be able to maintain healthier body weights. An emphasis on whole grains. So we have traditional foods that are whole grains. All our bread traditionally, mar'u, tanur, I can go on, is actually whole grain. And then we have additional things, burghul, frike. These are all naturally whole grain foods that are part of our traditional diet. More beans, more nuts and seeds, and of course, very importantly, more physical activity, but that was not part of the aim of my presentation, so I did not highlight it enough. And I want to thank you, and I open the floor to any possible questions.
Thank you, Dr. Fatih, for this amazing talk. Please, Dr. Nakhoul and Dr. Zoghbi, if you can join us.
Yes,
We have
I'm
a
here.
few questions. I'm gonna start with the first question that we had, and I think it is to Dr. Nakhoul. They are asking about the current crisis in Lebanon, and if we are in shortage of medicine, whether it's insulin or oral meds. And I think the problem here is they are asking on how to deal with it, and if we can switch between treatments. Can we do this? Since, as you said, Dr. Nakhoul, we have 8 pathways that diabetes is affected, and we can treat it in many ways. Can we do this? What do we do in case of shortage in Lebanon? Can you hear me, Dr. Nakhoul?
Yes, I'm sorry. I probably lost the connection. So you want me to enter the question about the shortage, right?
Exactly, and what to do, and if we can switch between meds, for example, that might have similar actions or actions that are complementary, or I don't know if we can do in another way, if possible.
Actually, first, let me say this is really unfortunate what is happening, because specifically there is many steps for the medication to go to the patients. First the company, and then the dealer, and then the pharmacist, and then the patient per se. So there is a little bit of a problem in each of those steps, making this quote unquote shortage. The companies say there's no shortage, we have the amount enough, but actually patients are having difficulties to get the drug. First, and I have many patients, and I think you do, and many of our panelists do have patients that are stocking medications in their house. Already they have like 6 or 7 months in the house, and this is like 7 new patients that are not being able to get the drug. This is one. Second, there's a strategy, a new strategy by the dealers to limit the quantity that they give to the pharmacy, and I'm okay with that, but we don't have a system. So we don't know if the patient took his medication or no. Now, like more and more pharmacists are requiring a chronic prescription to be in the pharmacy so that the patient can get his medication from the pharmacy and not everything is over the counter. Being a little bit better, but as you said, we have a lot of generics, we have a lot of family in the same, lot of molecules in the same family, and I have shown you the many types. So within the same family, I think it's okay to switch after just a call for the physician, but we need to be very careful in switching families without the knowledge of the treating physician.
And I think there's a question that goes with it, that what about the costs and the economic crisis? I think this is something we cannot do much about. Unfortunately, this is how much they cost. But I think like we have DiaLeb here, who have already helped so many patients get their medication with the help of many others. And I think if anyone has a problem, there are a lot of societies and a lot of NGOs who are dealing with this and helping people around. So I don't know if Dr. Jackie, you have any?
Yes, I am here with you. Thank you, Dr. Shadid. Actually, this is exactly the reason why we did our diabetes medication for all initiative. And later on, after the unfortunate Beirut blast, we created the diabetes relief initiative. Originally, when we started DiaLeb, we worked very hard. 80% of our work was awareness. We never thought to deal with medication, and we did not want that, but we were kind of forced to do that when we saw the imperative need and the people were getting desperate. And to say my opinion specifically about the shortage, because you know we have a large database of people, whether type 1 or type 2, registered with us as members. I say here the problem mainly is more for people with type 1 because they get very anxious if they do not find easily at the first pharmacy they walk into their insulin. And I've been dealing with that and trying to make them feel more comfortable, explaining to them that it's not exactly a shortage. But to be realistic, we do have a problem, whether it is the supply chain, it is the company, it is the import. No matter what reason it is, we need to make sure that our people get their insulin and diabetes medication on time. And again, this is exactly what pushed us to create those two initiatives. Thank you so much.
Exactly. Thank you, Dr. Jackie. This is very important, and thank you for helping people, whether type 1 or type 2 diabetic patients, to get their medication on time and the right medication. As Dr. Nakhour was saying, we can switch between the same family. So I think you are doing a great job. Thank you so much. I'm gonna look at the questions we have. So I have a question for Dr. Fakih, asking how can we control the carbohydrate intake and timing with mixed insulin, like they said, like Rhizodec, or we can have the premixes, the normal premixes. I think this is for type 1 diabetic patients more than type 2 diabetic patients, but can you please answer if you have
Sure. When it comes to insulin prescriptions, especially when a patient is placed on a full insulin regimen, what we use is a technique called advanced carbohydrate counting, where we compute the amount of total insulin prescribed to a patient and coordinate that with the amount of carbohydrate that is covered by 1 unit of rapid acting or regular acting insulin. However, these formulas only guide us in providing a primary prescription. In reality, the best way to do it is to initiate the primary prescription, and then we need our patient to self-monitor. And this is where Dr. Nancy's time and range discussion today also was very important. We are now using it a lot with patients who have a continuous glucose monitor. They help us understand and derive the insulin to carbohydrate ratio of that person specifically, which is a more accurate way of eventually adjusting the prescription and helping patients achieve what targets they need to achieve. So it's advanced carb counting. I couldn't explain the details of it now. That would require a whole workshop, not just a lecture.
Exactly. And I have another question for you, Dr. Fakih, because it came up. What about the kind of the healthiest bread for diabetic patients? We get this a lot from our patients, and I think from dietitians, they go to them asking them, what kind of bread do we eat? A whole wheat brand? Yeah.
Well, of course, we recommend, typically speaking, a whole grain bread. So whether it's made of whole wheat, we prefer definitely always whole grain bread and not just a white bread with added bran, which we call khibz al-khali, meaning that's what I mean. However, any bread that has either added fiber or that is whole grain in nature is superior to a refined bread, because the entire kernel or the whole grain is actually grinded and turned into flour, and we get the benefits of the nutrients. The protein is higher also, and the fiber content is higher. And that helps both in attenuating the rise in blood sugar, but also on the long term, as we said, higher intakes of fiber also have protective effects. So it's the idea of going back to whole grain foods, whether it's bread or rice or pasta or burghul, whichever it is. And, you know, patients with diabetes can enjoy virtually any food they wish to eat.
Thank you so much. I can see from the questions that Dr. Nakhoul has already answered many questions. I'm gonna go briefly on them because I think we are out of time. They asked about SGLT2s. Sorry?
I think we were short of time. That's why I typed the answer.
Okay. So what I'm gonna do is ask anyone who has who is interested with knowing the answers to go and check Dr. Nakhoul's answers on that. I think we covered everything, and I still have one question for Dr. Zughbi. As you said, we went from need to survive, then need to adapt, then need to stay in range and not have hypoglycemia. But nowadays, we are talking about a quality of life. Now, patients know they can have a safe insulin, know they can have a time in range that is good. They do not do hypoglycemia, but now they are asking for more. And this is important because quality of life in diabetic patients is important, especially that usually it starts at a young age, at the age of 7 and 8. And this is important for the patient, or for the kid and for his parents. So do we have any new ideas or any new inventions concerning insulin and the quality of life?
Thank you for the question. I think all we talked about is part of the quality of life. So quality of life is about having no hypoglycemia. It is about having a flexibility to adjust insulin dose with the meals, with the meal time. So all of this is quality of life. We still have the problem with insulin because till now insulin is an injectable drug. So patients do not like to have injections 1, 2, or 3 times. And then it is about the dosing of the insulin and the transport of the insulin. So what is going now in the research is going in this way. So we have more adapted pens. We have needles that are less painful. We have more smart pens, which will make errors and technical errors less frequent. And then we are starting to hope for new ways of administering insulin, like the puffs or the oral insulin, which is not a reality till now, but we hope that this will be a giant step toward a better quality of life for patients with diabetes.
Hopefully. Thank you so much. Dr. Nakhoul, Dr. Fakih, and Dr. Zughbi, thank you so much for your time. It was very important, and everything was, I think, very clear to everyone. I'm gonna give the hand to Dr. Malouf. I think we're gonna start our second panel.
Yes, before that, allow me to thank you, all the speakers of our first panel. You gave us incredibly interesting presentations. And thank you, Dr. Jadid, for being an excellent moderator. I would like to call your attention, maybe you may have noticed, this is a purely educational and scientific webinar, no sponsors, no pharmaceutical companies involved. And on behalf of DiaLeb and BAU, we are very proud of that. And here is another mention and a big thank you to the design department and to the ID department at BAU for being up to this high level of organization without the need of an organizing company. Thank you so much. Before we give the floor to the second panel, I will take 1 minute of your time to show you a very short video. And this is on behalf of DiaLeb, our tribute from the heart to all the nurses and caregivers out there. And mind you, the people participating in this video are people living with diabetes, speaking of their personal experiences with their own nurses.
موضوع اليوم العالمي للسكري لهالسنة بيسلط الضوء على أهمية دور الممرضين برعاية السكري.
بدي أشكر الممرضة سارة يلي ساعدتني اتخطى حاجز الخوف لما عملت أول إبرة أنسولين لبنتي نور.
أمي عندها السكري من النوع الثاني. شكر كتير كبير للممرض بول اللي ساعدني أهتم فيها بشكل أفضل.
ما بنسى أبداً الممرض يلي علمني كيف استعمل إبرة الأنسولين.
دورنا كأطباء بيتكامل مع دور الممرضين، خاصة خاصة بحسن إدارة السكري.
وبتذكر دايما الممرضة يلي علمتني أفحص السكر بالدم.
نعم، الممرضون يصنعون الفارق.
Thank you. And now I give the floor to Dr. Nisreen to go ahead with the second panel of this evening.
Thank you, Dr. Jackie. Please allow me to introduce Dr. Hala Ahmadiye. She is the moderator of the second panel. Dr. Hala Ahmadiye is a practicing endocrinologist and an assistant professor at the Faculty of Medicine, Beirut Arab University. She received her medical degree with distinction from the American University of Beirut and continued her residency training and fellowship in endocrinology at AUB. She pursued her Master's of Health Professional Education and is currently the chair of the Medical Education Department at the Faculty of Medicine, Beirut Arab University. She was awarded the Alpha Omega Alpha Award for her outstanding achievements. She is active in research focusing on endocrine disorders and is an author of several publications in this domain. Dr. Hala?
Thank you, Dr. Nisreen. Good evening, everyone. It's a pleasure to be moderating the second panel of today's webinar. Can you hear me? Are you able to hear me?
Yes,
okay.
yes.
Okay, so it's a pleasure to be moderating today's second panel of today's webinar, looking at the role of nurses in diabetes care and management. It's not a surprise that the World Diabetes Day for the year 2020 had a theme, Nurses Make the Difference for Diabetes, highlighting the important role that nurses have in the care of patients with diabetes mellitus. Before I present our honorable speakers, I would like to remind you that if you have any questions for the respective speakers, you can of course ask them in the question and answer tab, and we will hopefully tackle them by the end of the second panel. I'm now pleased to welcome our first honorable speaker, Dr. Mirna Doumet, who is a tenured founding associate professor and assistant dean at the Lebanese American University School of Nursing since 2011. She served as a nursing faculty at AUB before that, from 1990 to 2010. Dr. Doumet's scholarship reflects her expertise in oncology nursing, palliative care, and nursing workforce. Her publications shed the light for the first time on many gray areas in the field of oncology in Lebanon that were not explored or discussed before. She's a co-founder of a non-governmental organization, Awareness for Breast Cancer, and in 2018, she received the Past President Award from the International Society of Nurses in Cancer Care for her extensive work in the field of oncology. Dr. Mirna Doumet is the president of the Order of Nurses in Lebanon, and she's a fellow at the American Academy of Nursing. She's also a member on the Lebanese Ministry of Public Health National Committees for Breast Cancer Awareness and Palliative Care and Pain, and representative of the Ministry of Public Health on the Arab Nursing Council for Health. She's a reviewer of many different international nursing journals, and she would be presenting to us the art and science of nursing and diabetes care. Dr. Doumet, the floor is yours. You need to please unmute yourself.
Okay, good evening, good morning, or good afternoon, because I know that we have many colleagues in different continents. Before I go any further, I would like to thank the organizers for giving me the opportunity to be with you tonight. Before I start my presentation, I would like to salute all nurses because this year is the year of the nurse. And despite the fact that it was not easy on us, but again, nurses all over the globe and mainly our superheroes, Lebanese nurses, proved again to be the frontliners and the heartbeat of the healthcare system. So thank you very much for all what you are doing to safeguard the health of the Lebanese people. So if you want to describe nursing, nursing is both an art and a science. It's a heart and a mind. At heart lies the fundamental respect for human dignity. So as nurses, when we deal with human, with people, with patients, we deal with dignity, and we have an intuition that responds to patients' need. And of course, we don't only rely on this, but we also rely on the science, on the mind. And this is why we say that the base for nursing is the rigorous core learning. And in nursing, we have different specialties, in the different specialties, nurses develop complex skills, and each nurse in her or his specialty, they develop specific strength, passion, and expertise. And tonight, specifically, we'll be talking about diabetic nurses. So as we all know, and as our colleagues presented before, we know by now that diabetes is rising in the whole world. And the cause for this are many, mainly urbanization. And unfortunately, while preparing this presentation, I could not find any national prevalence of diabetes in Lebanon. And the latest numbers were related to 2009. But the International Diabetes Federation, it estimated the prevalence of diabetes in adults in Lebanon for the year 2020 to be at 12.9% for a total adult population or 4 million and a little bit more. So with this number, what is the role of the nursing staff with diabetes, and why this year was named after the nursing profession? Because as nurses, we have a very important role and we have clear responsibilities when we are dealing or treating patients with diabetes, whether those who have tests or those who would be diagnosed with diabetes. And of course, nurses have different roles in different places, whether clinical, whether social, whether educational, and using all these information that nurses are providing in different places would also help patients deal with their diabetes, and also it would help us to decrease the number of unnecessary referrals to specialists. And of course, it will also decrease the number of visits to clinics. And we always said it that if we invest in nursing, this will decrease the cost of the healthcare system. So colleagues have talked about the major complications of diabetes, and I will not dwell on this, but we all know as nurses that we have complications at two levels, the micro level and the macro level. And with all these implications at the micro or macro level, nurses would need to deal with patients. So the nurse's role and the necessary skills for nurses, of course, nurses need to have analytical skills. So when they are taking history for a patient, or when a patient is presenting for symptoms, they have to analyze all this data. Second, they need to have communication skills in terms to communicate to patients and to the family, because when we deal with diabetes type 1, we're not dealing only with the individual, we're dealing with the individual and the family, specifically in diabetes type 1. And many times in diabetes type 2, also if we are dealing with the husband or with a member of the family, we have to look who is cooking at home, who is responsible for getting the grocery and all the food, because this would impact the type of food that the patient would be eating. We need to pay attention to details because sometimes or many times patients do not reveal all information. So we have to be very keen while doing our interviews with them, while doing our assessment, physical assessment. And this means that we have to pay attention to details. Nurses need to have strong interpersonal skills because they need to interact with several individuals, and they need mainly the patient, the family, the physician, and the dietitian, sometimes the physiotherapist, and this requires strong interpersonal skills. Of course, we need to have leadership skills in order to be able to deal with a group of people, because as nursing profession, we while dealing with individuals, we follow the interprofessional practice or interprofessional clinical that is based on dealing with different individual while the patient is in the middle, which is we can summarize it in the patient-centered care. And in order to be able to deal with a big number of people, of course, we need to have leadership skills. And this also encompasses that nurses need to have a broad knowledge base in order to be able to have a good analytical skills, in order for them to pay attention to details, and in order to have good communication skills. So our responsibilities are many. We are responsible for patient education. We are responsible for their medications. We are responsible for their nutrition, because it's true that for nutrition, we have the dietitians, and we don't want to take the role of other professionals, colleague professionals. For the medications, we have the physicians who are responsible. But as it was mentioned before, because we are the frontliners, because we are there 24/24, 7 days a week, and we are closer to patient and to their families, this is why the responsibility lies within our hands, because the physician may see the patient once or twice per day. The dietitian may pass once, maximum twice a day, or during the patient stay. But nurses are always there as frontliners, and they are always there closer to the patient. Also, our role is to do screening and to do prevention and early detection. And for me, this is the most important role for nurses. Many people think and believe that our main role is within hospitals. I say no. It's true that the majority of our nurses work in hospitals, but our important role, the role that will have impact on finance, on society, on quality of life, is in the community, is before the individual reaches the hospital, is in screening, in prevention, and early detection. And believe me, many nurses think that this is not an important role, whereas I do believe that this is the most important role, because it will prevent individuals from developing complications, and it will decrease the hospital admission, and it will improve the quality of life. So what is nursing in a nutshell? So it is an autonomous and collaborative care of individuals of all ages. So we deal with all age groups. We deal with families, with communities. We deal with the sick and with the well people. And our role with the well people is more important and more needed than our role with the sick people. So nursing includes the promotion of health, the prevention of illness, the care of the ill, the disabled, and the dying people. And in the 21st century, nursing is known to be the glue that holds a patient healthcare journey together. So across the whole patient experience, wherever there is someone in need of care, we are there as nurses to work to identify and protect the needs of this individual. And of course, the reputation is that we provide compassion and dedication, but behind compassion and dedication, we are a very specialized profession. And I insist that we are a profession, and because we have evidence-based and we have nursing research that made us a discipline. And this discipline of nursing is constantly evolving to meet the needs of the society. So no matter what is their field of specialty, nurses utilize the same nursing process, which is a scientific method, which means that nursing is science, and we do the assessment, diagnosis, planning, implementation, and evaluation every time we approach an individual, whether for prevention, intervention, or later on post-hospital. So what do exactly nurses do? And we cannot have one single answer. So our responsibility is very wide. So we can move from making acute treatment decision to providing inoculations in schools. But the main common denominator for each role that we are playing is the skill and drive that it takes to be a nurse. So it's not easy to be a nurse. And through our long-term monitoring of patients' behavior and knowledge-based expertise, we are the best as nurses to take care of an encompassing view of a patient's well-being. Why? Because we are all the time available, continuously assessing the patient's condition. And the ICN, International Council of Nurses, believe that health is a human right. And ICN is at the forefront of advocating for access to health, and nurses are the key to delivering it. This is why the WHO this year declared it the year 2020 as the International Year of the Nurse and the Midwife. So all over the world, we have individuals, we have communities that are suffering from illness. Why? Because lack of accessibility and affordability to healthcare. But also, we have to remember something very important, that the right to health applies to nurses as well. If we don't have healthy nurses, we cannot have quality care or quality life for patients. So we all know that improved quality and safety for patients depends on positive working environment for staff. And we have evidence for this. We have research, nursing research, that proves that if nurses are not happy, if they don't have a positive, welcoming working environment, the satisfaction would be low, and this would impact the safety and the care and the satisfaction of patients. This all means that the right to a safe working environment, adequate remuneration, and access to resources and education is a right for every nurse. Also, we must add to this the right to be heard. So nurses have the right to be heard and the right to have a voice in decision-making and policy development implementation. The treatment of a disease may be entirely impersonal, but the care of a patient must be completely personal. And this is what we believe in as nurses. There is no other profession that attends to people's need in their most vulnerable periods of time as nursing does. And I don't need to repeat why. So the relationship between the client and the nurse provide a unique and intimate view of a person's life. So nurses spend most of their time with their patients and their family. And of course, because of this, they have the first-hand knowledge of the stories that will impact the health and the well-being of the patient. So everyone has a story, and every story has the potential to improve the health system. And this would enable individuals and community to achieve their highest attainable standard of health. So from all these insights comes the power of change. So nurses have this power of change because they have the knowledge of patient expertise and patient lived experience. So nurses, because of their unique lived experience with patients, they have a complete understanding, or must have a complete understanding of the health system, because they are aware of the strengths, of the weaknesses, and how to overcome the challenges that are posed by a broken or dysfunctional system. So with health system attempting to improve access, affordability, quality, efficiency, equity, and people-centeredness, nursing knowledge and commitment to the health and well-being of individuals needs to be effectively heard and empowered and mobilized. So for this to be a reality, nursing perspectives and opinion must be represented at the highest level of health leadership and integrated into decision-making. So nursing voice must be heard, and mechanisms need to be developed to engage with nurses at all levels to affect lasting and worthy change. And in order to make this happen, it's a duty for us as nurses to have a better understanding of the highly complex nature of policy influence and policy making. So we have rights and we have duties. So our duty is to provide care, but also we need to be immersed in policy influence and policy making if we would like our voice to be heard. So if we do not engage consumers, patients, and family members in healthcare process, we will not be effective at eliminating inequalities and improving health for all. So thank you very much, and congratulations for DiaLeb, for BAU, for this successful webinar. And together we can beat diabetes.
Thank you, Dr. Doumet, for an outstanding presentation and for highlighting the important role that nurses play. They have a lot of role to do in diabetes care. Please stay with us towards the end so you would answer some of the questions. Now I would like to present our second speaker, Dr. Ahmed Tassi. He's a colleague of mine. He's an assistant professor at the Faculty of Health Sciences at Beirut Arab University. He's an education consultant with a wide experience in developing and providing adult education and training for healthcare professionals. Actually, he has more than 15 years of experience in healthcare delivery and training in Lebanon, United Kingdom, and in Saudi Arabia. Dr. Ahmed is a holder of bachelor degree of nursing. He got it from Lebanon, and then he got his master's degree in nursing from UK and the doctoral degree from the USA. He has sufficient experience in improving and designing electronic learning management training and educational systems. Experience with sufficient knowledge in healthcare research, evidence-based practices, managing data, and using research statistical tools, including several publications in highly ranked journals. He's also the director of the Beirut Arab University Life Support American Heart Association International Training Center. It's a MENA reference center. He would hopefully be presenting development of educational programs to improve nursing care for patients with diabetes. Dr. Ahmed, the floor is yours.
Thank you, Dr. Hala. It is a pleasure to be with you all tonight, and good evening for Dr. Bolton, Dr. Samdeed, and thank you for Jackie and Nasreen for the nice organization. I think I'll be sharing my presentation right now. Okay. And I think we should also thank a lot the audience, and hopefully they were enjoying this fruitful webinar. Okay, is it clear like this? I guess so. So tonight what we're going to be talking about is about the diabetes nursing education role in managing and improving diabetic patient care. I'll try to be short. I know everybody could be tired by the end of today's webinar, but we'll go through it. There is some facts. I'm just going to remind you with some facts about the diabetes. Diabetes continue to be in rise for sure. We spoke about that a lot tonight. Diabetes patients require a lifelong care. It's a continuous issue and is going to continue in the coming years. There are new treatments and services developing all the time. And with these treatments and services, for sure, there's needing more training and more competencies for that. There are local and global challenges in the recruitment and training of nurses to support the people with diabetes. We have seen earlier with Dr. Dumut how this is in a way or another facing the whole system. The treatment of diabetes is complex. We all know that. It is involving numerous lifestyle adaptations and require a great deal of teaching and support. When we're talking about the teaching and support, we always focus, or we mostly focus on teaching and the support for the patients, but also there's the issue about teaching and support for the providers themselves. Managing patients with diabetes effectively require a great deal of time, effort, and patience. However, the nurses are there. They are the active advocates, and they always advocate for the diabetes sufferers. The patients, the nurses actually, they have this major role of playing the role of advocacy. They are there to protect the patient and to defend his needs and to protect him safely and effectively. When we're talking about education and training, we say that educated and adequately trained diabetes nurses are able to deliver quality, cost-effective care by applying all the combined skills and knowledge from their training as diabetic nurses, whether they are nurses, educators, nurse specialists, or nurse practitioners. When we're talking about diabetic nurse practitioners, we say that they can serve as a role model and educators, offering professional education in diabetes care and management to their colleague in primary care that have in many countries expanded to include the diagnosis and medical management in both acute and chronic conditions. For sure, this concept of nurse and practitioner, especially when they're in the expansion of diagnosis and medical management, we still lack it in Lebanon in a way or another. However, we are having very promising definitions of practitioners nowadays in some of the hospitals, and I think we are in the right track. When we talk in general about the specialized diabetic nurses, we say they have a big role to play in the direct patient care and practicing the direct patient care. They have a big role to play as a practitioners in terms of the procedures and the therapies. They are the educators. They are the one who are providing education for the patient and the family and the community. These nurses are the ones who play also as managers. They are managing the care, and they play a major role in leadership and for the patient and their families. They have also a researcher role. They play a major role in the quality, in doing research, and in advancing the diabetic caring and treatment itself. And for sure, they always are skilled communicators. They are professional communicators. And after all, they are the ones who should be always act as real professionals. This is the most important role for the specialist, any specialized diabetic nurse. They play a major role as a professional that play the role of a patient advocate, that knows the laws very well, and that practice ethically, confidentially, and with privacy. When we talk about these type of roles, we come to the point where who is evaluating an individual's ability to achieve the expectations stated in his or her job description. The idea here is about the competency itself. When we're talking about education and training, there is a very major important there, which is who is evaluating whether this is doing the role that he's supposed to be doing. We know in terms of the competence itself, there is a lot of things we understand about the practice itself, but for the nurses at the bedside. However, caring for the patients with the diabetes requires nurses with education skills and experience, not only in the direct care, but also we need nurses who are experienced in the required to evaluate the competence itself. So we're not only talking about the experience in dealing with the direct care, but also experience in evaluating the competencies of those carers at the bedside. When we are talking about this, that means we're talking about measuring the performance. There's a lot of models being there. Most of you probably are familiar with. There's some of the models about met, not met, about met, not met, or exceed, or competence, or proficient, and something like that. There's several models. There's in nursing, we know a lot about the Benner's model, for sure. It's been there for many years. And they talk a lot about the Benner. She talks about the novice to the expert. For sure, those starts from novice, and then later on, when they start in working in the real life in the hospitals, they become advanced beginners, and later on they are independent and become competent, and then proficient and experts at some level. However, when we're talking about monitoring the performance, we're not only talking about the bedside nurse's performance. The key point here for the advancement of care is that what about the evaluators or the assessors' performance? That's very important, is that we should be looking at some time about those assessors or the evaluators' performance themselves. And to do so, we're doing the same thing. We're not doing any new models or anything at all, but we have to be careful very much here is in what? We have to be very careful, and the point is that we're not looking for experts. Is somebody an expert in doing a task? It doesn't make him a competent in being an assessor. It doesn't make him a competent in even teaching the task. You could be expert in something, but you could be an awful teacher. You could be having good skills, even good knowledge, but not everyone who has good knowledge and skills are good teachers. And this is a very key issue in measuring the performance, is that we need to be measuring the performance of the assessors. What we're looking for competent assessors. We're not really that much interested to have really expert assessors. It's good to have expert assessors, but what we're looking for is that they have the minimal qualification to be assessors, to be role models, to be educators and diabetic nurse specialists. That's the key. That's the thing we need to be looking at. When we know what we're looking, what we're facing, that means this is the way to prepare those assessors. Then we look for the training, and then we know when we know these key performance indicators or key performances points, then we know what they need from training, what we need them to put them at what level of what education they need to support them to do this task. So there was a need for something called internal moderator, a validator, some person there that provides the support, the advice, and the guidance for the assessors. What we do currently in many of the hospitals, we do that. We do that in different names, in different ways. However, this needs to be very structured, and it doesn't need to be in a hospital. Whether in any healthcare setting, this needs to be very structured in a good way. So the internal validator, what they do, they assess, they support the assessors and provide them with the resources to carry out their role effectively. They do look after those assessors who are looking after our carers, who are looking after our patients. Does that make it a little bit complicated? Not much, no? So if we look into this model here, that's our client. What nurses look at our patients all the time. They are our clients. They are the one we look after, like the barber, you know. We are the one who do that. We look after them. We need them to be safe, happy, and we provide all the support for them. But the first thing you need is not to harm them, to make them in a safe environment. Then we look for the quality of care. So when these nurses, to protect these patients, we need somebody to be assessing those carers and somebody looking after their competence. However, at one stage, we need that internal validator to be looking from behind, from far away after those assessors and about those process, that is it going well or not? Because sometimes the assessors themselves could be unsafe in a way or another, if we can say that. And what we be doing, this is the best way, then we could be monitoring these performances in an ideal way. Okay, I'm not gonna be late with that. Let's go in short. In short, what we can say is that nurses are vital. in the global fight against diabetes. This is a message we have seen today, and we would like everybody to be reminded that they are vital in the global fight. Nurses play a major role as patient advocates. They are there. Nurses are supposed to be there to defend the patient's rights, to support the patient, and to be that barrier from the harm for the patient. Those are the nurses who deal with the physicians. These are the nurses who deals with the nutritionist. They are the one who deals and overlook the laboratory findings, the imaging, and the everything to do with this patient. And that's why they are the advocates. They are there to look after the patient's interest and to be the frontliners in defending their rights, not only rights, but also their safety and making sure of the effective treatment and monitoring their effective treatment and the patient response to that. Education has always been and will remain the cornerstone for healthcare. For healthcare, whether we're talking about education for the patient, education for the family, education for the community, and as we've seen earlier with Dr. Domot with the patient-centered care, as putting the patient there at the center of care. And education also we always need to remember that this education needs to be also for nurses. Education to make educational programs for nurses, for the carers themselves. We always we focus on looking after the patient, but by looking after the carers, we are really looking after the patients. We need to always remember that. When we are looking after the carers, this is one of the ways to be looking after the patients. And proper performance management is a key for the competence retention to keep those nurses, diabetic nurses, competent and retain their competencies at all times. Diabetic nursing education is the key for appropriate management and improvement of diabetic patient care. There is just a few more recommendations. One of the recommendations is that the trend for more nurses education and training to become diabetic educators, diabetic specialists, or nurse practitioners can only lead to a better care for people with diabetes. We always need to look into that. Employers need to look into that when those nurses want to do their studies, they want to do their education to become more specialized, what they're going to serve in the end, they will be serving those patients. Collaboration with a physician and other practitioners in the practice work both ways and benefit both the providers and the practitioner and the patients. And lastly, healthcare organizations need to invest not only in recruiting of more nurses as we see all the time, but also in the education and training so nurses can provide the best possible support to people living with the diabetes. Those healthcare organizations need to be looking at this investment. They are investing in these nurses. It's not only the nurse that we need to be looking after continuing education and training, but the health organizations themselves need to invest into that and need to work in doing so. Thank you. This is all for me, and I hope you enjoy the rest of the webinar.
Thank you, Dr. Ahmad, for a very nice presentation and for highlighting the importance of not only educating the patients, but also the healthcare professionals who are providing care for our patients. Last but not least, I would like to present our third speaker, Dr. Najwa Al-Jirjis Lighawi. She has a Bachelor of Science in Nursing from the Lebanese University. Then she got a Master in Public Health from the American University of Beirut and a PhD degree in Therapeutic Patient Education from University at Alsace, France. She is currently an Assistant Professor of Nursing at the Faculty of Nursing and Health Sciences at NDU. Dr. Jirjis has more than 15 years of teaching experience at the Lebanese University and other academic institutions like Kuwait University, Holy Spirit University of Kaslik, and St. Joseph University. She supervised research theses for medical graduate and undergraduate nursing students. She coordinated different research projects at Kuwait University and at the Institute for Development Research Advocacy and Applied Care. She has a number of publications in several peer-reviewed journals, and she is a member of the Committee of the Nursing Colloquium at the Ministry of Education and Higher Education, and she's currently chairing the Continuing Education Committee at the Order of Nurses in Lebanon. She would present Controlling Diabetes in the Community, a Nursing Approach in the Primary Care Setting in Lebanon. Dr. Najma?
Yes. Okay, good
Okay.
evening. Can you hear me?
Yes, we can.
Okay, and you can see the presentation?
Yes, we can see it as well.
Okay. Good evening, everybody. I know that you are a little bit tired. You know, this is, I am the last one to present today. I would like to thank the organizers for inviting me for this, to be a speaker in this controlling diabetes, especially that my PhD is on controlling diabetes. And I like to share also what I have learned in my thesis and what policy we can do in Lebanon for diabetic people. Because what I learned from this experience that nursing, they have a very important role in controlling diabetes in the community. Especially now I will be summarizing what my colleagues also have said, because there is a nursing approach in primary care setting in Lebanon. As most of you presented today, we have the primary level of prevention, which is the health education, the lifestyle changes before getting the diabetes. We have the secondary level, which is the screening for diabetes. So when we are screening, we can help people catch up with their diabetes and not getting the disease. And we have the third level, which is when people, they get the diabetes and they have to live with. So my thesis, I worked with people who have already the diabetes. Okay, so I will be going through my presentation. And today, this is a tribute for nurses. I will, during my presentation, I'll show you what I have discovered in this thesis. Okay, oh, it's not working. Okay, sorry. So first of all, this is the definition with some figures that most of you already know. We know the risk factors, especially that we have many controllable risk factors for diabetes, so we can work over that. The complications also, you have already highlighted the micro and macrovascular, and as you know, also we have short and long-term complications. But what is the most important thing, that strict control of blood sugar, blood pressure, and cholesterol, we can reduce these complications. So whenever a person has the diabetes, as nurses, we have a very, very important role in the community. And here I will be stressing on the community more than the hospital, how to help people with diabetes. And over the past 20 years, the responsibility of care, it shifted from hospitals to primary care. What does it mean? Normally, people, when they are sick, they go to the hospital, they seek help. So in the primary care centers, a lot of things can be done. Prevention of the disease, screening, and management sometimes. So this is where primary care has a very important role. Despite the fact that there are many guidelines for diabetes management, okay, but still we have many problems with diabetes. And today, Dr. Sandeed, he exposed to us that the numbers are increasing. When the numbers are increasing and they say that 50% of people, they have already diabetes and we don't know, or they don't know, okay? So it means that all these efforts are not yet efficient. And this is very important thing to highlight. So why? Even people who have diabetes, they don't have what you call compliance. What does it mean, compliance? Compliance, it means that they have to follow what the physician or the healthcare provider or the nurse or the dietitian or the psychologist, there are many This is a multidisciplinary approach. They help them with their diabetes, so it's not there. So many patients with diabetes still they are living many risks in their life. So here there are a wide range of interventions. They are helping to improve the provision of diabetic care and a better metabolic control. What does it mean, a better metabolic control? Today I learned something that Dr. Nahul exposed about time in range, something like that. But I wonder, today we are asking about the cost. We are living in Lebanon. It means that we will have many difficulties later on in accessing the healthcare and maybe these innovative technologies that we really need maybe in diabetes management. So better metabolic control, still maybe we have to rely on the HbA1c. Here, because this is a tribute to nurses, I like to talk about one of the nurses. When I studied nurses, I liked her. Her name is Dorothy Elizabeth Orem, and she's one of the founders of the self-care theory, and we call it the Orem model of nursing. What does it mean? Dorothy Orem, and I liked, when I studied nursing many years ago, I liked what she thought. And she thought that we have to help an individual to take care of himself or herself. Why? Because they are partners in care. And as healthcare providers or nurses or physicians, when we are offering this care to the other who is the sick or the well, we have to teach them how to take care of themselves. And this is what we call the Orem model of nursing. And she said that this is the individual ability to provide self-care. Sure, not everyone can do the self-care, but in general, people should be more responsible, especially with the patient's rights and the human rights, to perform on own behalf, maintaining life, health, and well-being. So she defined the theory of self-care, self-care deficit theory, and the nursing system. And she defined also nursing. I will not go through, already Dr. Dumet, she went through. But this is the practice of activities individuals initiate, perform on their own in maintaining life, health, and well-being. And this is the individual ability to self-care. Yani, it means that the patient here, he should learn, he will be the learner how to take care of himself or herself. And this is very important when we are talking about diabetes. Healthcare providers, they cannot do by themselves. They have to involve the patient as a partner. And this is why we have many important challenges in effective diabetes management. And this is why clinicians, patients, they are overwhelmed by the need to address the specific diabetic treatment goals. So here in this webinar, I will give some examples from the literature, what has been done. So this is in 2006. I said that the late 20 years, we started with the interventions. This was a systematic review of interventions to improve diabetes care in socially disadvantaged populations. And in the systematic review, they talked what they have done as interventions, but we didn't see nurses in these interventions. They were part of a multidisciplinary team. Afterwards, patient education in type 2 diabetes, it was a randomized controlled trial, 1-year follow-up study. And these experimental studies are very, very important when we are measuring patient education in type 2 diabetes. And already the people, they have already the disease, and we are teaching and we are seeing what will happen with the education. Educational interventions aiming at improving adherence to treatment recommendations, because people, they know they are sick, they go to the physician, but they don't follow the recommendations. And this is why the complications are there, the diabetes is not controlled, and the complications, and the patient, he goes to the hospital. And here this study was done in, and this is a Department of Nursing and Midwifery that in joining efforts with the Department of General Practice, Interdisciplinary Healthcare and Geriatrics in Belgium, they work together, and a Center of Primary Care Healthcare Studies, to see what's happening, and this is a sub-analysis of a systematic review. Nurses' role in diabetes care, a review, it was done in 2010. Also, it was done in Iran. Patient education and counseling, also efficacy of therapeutic patient education, chronic diseases and obesity. I will talk about it because I took this model of therapeutic patient education. Effect of education given to patients type 2 diabetes mellitus on self-care, and this is here very important. We have to educate people how to take care and how to be partners in care. Self-efficacy, self-management, glycemic control in adults with diabetes mellitus, randomized control trial, family-oriented self-management. Here they involve the family also in taking care of the diabetic patients, and to improve self-efficacy, glycemic control, quality of life, and this has been done in Australia and Thailand. Outcomes of educational interventions in type 2. Évaluation d'une intervention infirmière. This article has been published by a Lebanese nurse. She is a PhD holder at USG called Randa Atalla. Also, this is something published in 2019, and I believe this is a very good start for nursing involved in the diabetic education. This is also another consensus here, and we see down the Association of Nurse Practitioners. And as you know, in Lebanon, we don't have many nurse practitioners working autonomously. So what we learn from all these, and there are too many other papers, who are the patients, who are the research participants, who are the educators, multidisciplinary, peer-to-peer, family members, what is the method of teaching, collaborative, individual, by phone, online, blended, etc. So we found in many randomized controlled trials all that. What is the content of the education, the duration, the indicators, the HbA1c, the self-care activities, self-efficacy, quality of life, and if this intervention is efficient or not. Many of these studies, they show that they are really very efficient, and there was efficacy in making the life of diabetic patients better. So I will show, so this is the role of nurses, as I said, at 3 different levels. I will talk about, Okay, I will show you what I did in my thesis. It was the title, Nursing Approach in a Primary Care Setting in Lebanon, the effect of therapeutic patient education on DMSES, it means Diabetes Management Self-Efficacy Scale, SDSCA, Self-Diabetes Self-Care Activities, quality of life among type 2 diabetic patients, and sure, I'll talk about the compliance. So this is, I published my article, it was published in June, effects of therapeutic education on self-efficacy, self-care activities, glycemic control of type 2 diabetic patients in a primary healthcare center in Lebanon. So, and it was published in the Journal of Diabetes and Metabolic Disorders. So what is the problem statement? First of all, the prevalence of diabetes type 2 in Lebanon, I put it 12%. As Dr. Doumet said, no data since 2009. And there are differences in many articles. And sometimes I find 14.99, 15%. So I just took this number. But even though 12% is a very high prevalence, progression of diabetes, especially poor glycemic control, threatening complications, cardiovascular, retinopathy, food problems, etc. So people who have diabetes are suffering from the complications. Therapeutic compliance, it is 50%. Quality of life, self-efficacy, self-care activities, and diabetes type 2 are not quantified. And we don't have a Lebanese legislation for therapeutic education. Why I want to, this is, what does it mean, self-care activities? Because as we have said before, there is an aim for diabetes control. So whenever we are saying we have a healthy eating, being active monitoring, So this has been given through a scale. And on this scale, you know, we say, how long do you do this? It was developed by Tubers et al. And this is how we count, we can say, or we assess the self-care activities of a person with diabetes. Self-efficacy, what does it mean? There is a theory of self-efficacy. Albert Bandura, he's the one who initiated it, and he says that this is the belief of individuals in their ability to carry out a successful practice. Sometimes patients are not ready to take care of themselves. Or, as you know, anyone who is known as sick, sometimes they have the denial stage, they are negotiating, they are angry, they don't want to take care of themselves, and they don't believe that they can do it successfully. So self-efficacy is very important whenever we have a patient with a chronic disease, and especially diabetes type 2, and there is a scale that I use for this purpose. The quality of life, what does it mean? This is the perception of an individual for their position in life, in the context of the culture, value systems in which they live, and in relation to their goals. I use an instrument called SF36, and this measures the quality of life of the patient. Therapeutic patient education. This is a very, very important concept. You know, WHO in 1998, they listed 60 chronic diseases, including diabetes type 2. And in this definition, they said that, and they encouraged all the people who are registered with WHO to implement this therapeutic education. Why? Because it enables patients to acquire and maintain skills that allow them to manage their treatment in an optimal manner in order to achieve a balance between the disease and themselves. It's a continuous process, okay? So it helps patients, families, okay? So this concept has been issued by WHO in 1998. What I want to tell you, I did my PhD in France, in Haute-Alsace. In 2010, in France, they issued all the legislations regarding the therapeutic patient education. What does it mean? It means that, for example, I can give you an example. If you fall down and you have a fracture, what do? You go to an orthopedic surgeon, you do the X-ray, you may have a surgery or not, depending on the what happened. But what is the most important? That when you finish, for example, you have 6 sessions of physical therapy, and you go for these 6 sessions or 10 sessions of physical therapy. But if a patient with a chronic disease or diabetes type 1 or type 2, he is sick or she is sick, and they go to a doctor and they just tell them, go home, you are sick, what they do? Nothing. And this is the therapeutic education. There in France, what happens? Whenever a patient is diagnosed with a chronic disease, they go to a center for therapeutic education. They are obliged by law to go and follow sessions regarding their disease, because they believe that these people, if they follow this education, they will take care of themselves, and as a consequence, they will have less complications and the healthcare system is better. And they have refresher courses every 6 months, every 1 year, and they opened in France something we call it University of Patients, Université des Patients. And there are many people who are working in this field. They have developed the competencies of the healthcare workers, of the nurses in this domain. And I can tell you, in 2010, they mentioned that the nurses, they will take care of this therapeutic education. In 2013, they made a change because they have a shortage in nursing. They said, no, anyone in education, they can learn and they can go and follow this education. So, so if you look, what happens when we are following a program of therapeutic education. This is in French. I will explain it. Savoir, it means knowledge. Savoir-être, it means behavior. And savoir-faire, it means skills. And whatever here people are learning, okay, why? Because they say that they have to improve their health status, they have to improve compliance, and they have to improve their quality of life. So whatever they are doing in this program, so they put objectives, they put actions, and there is real goals to have at the end of this training. So this is cognitive behavioral knowledge skills. Yani if I am saying, for example, skills, effective self-monitoring of blood glucose, okay, knowledge about nutrition, physical activity. So it is there in the program. And it depends on every disease. Maybe they need 10 hours, 30 hours, 40 hours, and they have to learn them, okay, because they have to take care of themselves. So, and this is what they call that the patients, they should acquire skills, competencies at the end of their, when they do this training. They should select the objectives for the management of their disease, modify their nutrition accordingly, take prescribed medicines, increase physical activity, and so on. And what is the most important thing here, that it is an individualized program, and every patient knows what he can apply. In order to have what you call the self-efficacy, the patient has to be part of this program, and he has to share with the healthcare worker about what he can do.
Dr. Najwa, sorry for the interruption. There is 1 minute left due to time limitation.
Okay, sorry. I will go through very fast. So the expected result decrease in cases of diabetic coma, all the complications, amputations, decreased complications. Okay. So at quality life, my research, I had 100 diabetic patients. It was a randomized control trial, experimental and control. I used the instruments before and after. I gave, there is an inclusion and exclusion criteria that I respected. I put the study design, and this is the questionnaire, the data collection, multidisciplinary team. There was a physician, a nurse, psychologist, dietitian. There was like 6 workshop topics. We did the data collection before and after, and every 15, it was blind, and the controls, they don't know the experimental group, and the workshop topics were these. Self-care management was taught to the patients. We did the data analysis. I get all the ethical permissions, and the results, they showed that the 2 groups were comparable, and the health behavior also, they were comparable. And at the end, the HbA1c improved after the therapeutic education, as well as the self-efficacy, the self-care activities, the quality of life. In conclusion, therapeutic education is very beneficial in terms of self-efficacy, self-care, and the most important recommendations to communicate the results, to promote issuing a legislation for therapeutic education, initiate the training for professionals in undergraduate studies, and apply this model in the primary care centers for chronic diseases, especially type 2 diabetes. And nurses make the difference. Thank you.
Thank you for a very comprehensive presentation. It was amazing. There was a question for Dr. Mirna Doumet that was answered by her in the question and answer. I'd like to ask a question to Dr. Najwa, please. With Dr. Santit mentioned in the beginning that still many patients don't get enough patient diabetes care. So can you, and you already mentioned to us how important that is for the patients to actually self-care for themselves as well. Can you please mention some of the barriers for that, for not getting adequate education?
It's not only about adequate education. You know that people, when they have diabetes, sometimes they don't have, the signs and symptoms, and sometimes they don't know, and they don't really appreciate the risks of having diabetes and long-term complications. And this is why they are negligent about their health. This is why awareness is very important, and especially having like diabetic clinics, they take care of them, they follow them, because sometimes also we have many barriers, even financial nowadays, and even for doing a hemoglyco test nowadays, it's really a financial barrier for our population.
Okay, thank you very much. I would hand it now to Dr. Nasreen Bisar, who would be doing the closing remarks. And thank you everyone for joining us.
Thank you.
Thank you, Dr. Hala. Thank you very much. At the end of this webinar, I want to thank the IT specialist, Mr. Anas Alawa, who was running the platform for us today, and thank all the speakers and the moderators and the audience for your interest and active participation. And I would like to kindly ask you to complete the very short evaluation of the event that will appear while you leave the meeting. I hope you enjoyed all the topics presented today and you will join us in future events. I'll hand it to Dr. Jackie now. Dr. Jackie.
Thank you. I would like to thank from my end all the speakers who were with us tonight. Excellent presentations. I can't say anything less. Thank you to special thanks to Dr. Sandid, who remained with us, as well as the other speakers to the end. Dr. Mirna Doumet, I don't want to name all of you. You were all excellent speakers. I would like to invite the attendees to check the IDF School of Diabetes for some very interesting courses related to nurses, role of nurses, role of diabetes educator, and they can get a certificate from there as well. And also I would like to invite you to check DiaLeb's activities on all our social media platforms. We recently did a study on a sample of 2,000 individuals in Lebanon related to diabetes. It's our first research study, and we will be publishing very soon. Hopefully we have a project to start a new survey and a new research study soon. And what else can I say? Really, thank you all so much for bearing with us. Long time. Dr. Sandid has something to tell us, please.
Yes, sorry. I am very proud of this activity because it puts the tram of the tracks. Can I speak in Arabic, maybe?
تفضل.
Because I am French educated, sorry. هلا الحقيقة ما في حدا من الموجودين إلا عطى الماكسيموم من المعلومات، وهو بحد ذاته كل واحد يعتبر قدرة كبيرة. المطلوب أنا برأيي السنة هاي نحط إيدينا بإيدين بعض ونشتغل على الامبلمنتيشن، مش بس نضلنا بالتيوري وكذا. أنا بقترح إنه عبر دكتورة جاكي كلنا سوا نعطي أفكار ونعمل واتساب جروب، لأنه هلأ عم نجمع قديش فينا بالاي دي اف. عندنا كتير من المواد اللي فينا نعطيها in 3 languages، عربي، فرنسي، إنجليزي، حتى ندرب مش بس نيرسينج educators، لأنه تعرفوا قديش بحاجة للمثقفين الصحيين. صدقوني ديابيتس لنا علينا كتير ديابيتك بيشنت، والديابيتس بلبنان في كتير لاك لازم نسكره ونشتغل عليه. شكرا لكم، شكرا جاكي، شكرا للجميع، والله يوفقكم.
Thank you, Dr. Sandid. بفتكر إنه الأذان صاغي أكيد لندائك. I think we are all ready to join efforts. They showed us through their presentations how willing they are to help the community. All of them are already helping the community, each one in their own specialties. Big thanks to you. مرة تانية برجع بقول thank you, Nasreen. You did a wonderful job. Thank you, Anas. You were bearing with us during all this time of preparation. It paid off. Thank you all. For the attendees also, طولنا عليكم. Thanks, and until another activity, until another webinar, stay well and stay safe. Thank you all.
Thank you.
Thank you.